One, we are live now.
Good evening, everybody. Myself, Dr. Vishal Dave, Medical Advisor, Intas Pharmaceuticals. On behalf of Intas, I welcome you all for this Synergy Club Webinar 3 on the topic Combat Postpartum Hemorrhage. Before
Hello.
starting the webinar, we will have lamp lighting.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते
Dr. Neetu, can you please read out the program after this?
शुभं
Yes,
कुरुत्वं
ma'am.
कल्याणम् आरोग्यं धनसम्पदः
I would like to introduce Dr. Monica Singh. Dr. Monica Singh is National Executive Member, ISAR. She is also Founder President, ISOPA Chapter of Bhopal. She is Vice President, Bhopal Obstetrics and Gynec Society. She is Vice President of Bhopal Menopause Society. She is also convener of ISAR Perfection Series, Foxy Symbiosis Series, and the present, the Synergy Academic Club. Now I would like to hand over the session to Dr. Monica Singh.
Good evening, everyone.
Yeah, Neetu, I'm back. So, Neetu,
Yes,
just do me a favor, please. You just mail the faculty link to Dr. Anju Soni, madam.
yes, ma'am.
And Dr. Anju Soni's madam's email ID, I am posting in our group.
Yes, ma'am.
Madam is waiting, and somehow my email did not reach her. So, the email I have sent in our group, please mail the faculty link to madam. Good evening, everyone. Welcome to the Synergy Academic Club. And today is our episode 3. We are very, very happy to say that Synergy Club has got a very good response all over India. Excuse me. Dr. Neetu, there is another request for email of the program faculty link to Dr. Sheila Mane.
Yes, ma'am.
Please mail to Dr. Sheila Mane immediately and Anju
Yes,
Soni.
ma'am.
So the Synergy Club has reached its episode 3, and this episode is on combating a menace called the postpartum hemorrhage. I was just having a conversation with Dr. Nalini Mishra ma'am, who is Dean, Ellen Medical College, Bhopal, and Madam shared with me that the incidence is still in tertiary care centers. It is over 4% of women suffer from PPH, and gradually from the atonic causes in rural setups, we are shifting to the placenta accreta spectrum and the adherent, morbidly adherent placentas, which are causing grievous and serious PPH. So we have got great experts today who will be deliberating on this issue. And this episode of Synergy Club is in association with the Bagalkot OBGY Society, Bidar OBGY Society, Chitra Durga OBGY Society, and Gulbarga OBGY Society. Today we have a veritable feast of lectures for all of you to listen. And those of you who miss listening to today's deliberations can always log into the YouTube link and watch it at your convenience whenever you have time. So the first lecture is by Dr. Sheila Vimane, ma'am, who is ICOG Vice Chair. Madam will be speaking on PPH prevention, perception, and management. The next talk is by Chairperson. The next talk is by Dr. Mitra Saxena, ma'am. She'll be speaking on the rationale of stepwise devascularization in PPH. And the third talk is by Dr. Nalini Mishra, ma'am herself. She'll be speaking on obstetric hemorrhage and coagulation. So we are going to, have a great symposium today. And I would love to introduce our guest today. We have with us Dr. Anju Soni, ma'am, who is the chief guest for today. Has ma'am been able to join, Nandini?
Ma'am sent her just now. She will join just.
Okay. So let her join and then I'll read the CV when she joins. We also have with us a special guest, and our special guest is Dr. Rekha Rajendra Kumar ma'am from Bengaluru. Madam is there with us. So welcome, ma'am. Welcome to Synergy. It is lovely to have you amongst us. And I would like to introduce ma'am from her illustrious CV. Madam is the medical director of ma'am, just excuse me. Anju Soni ma'am is having some problem.
Monica, you continue. Should I talk to her?
Yeah, thank you, Archana. I think I'll continue. And Dr. Neetu, please talk to Anju Soni ma'am again, and she was needing some guidance with the registration process, I think. Dr. Rekha Rajendra Kumar ma'am, I'm sorry for the interruption. She is Medical Director of Miracle IVF Hospital, Stamina Hospital in Bangalore, practicing for the last 33 years, and President of the Bangalore Society of OBGYN 24 to 25. Madam has been a very, very avid academician. She has got the first rank in MD University examination, 7th rank in the Bangalore University MBBS examination, and she's been the All India topper of ICOG Reproductive Medicine examination. Madam has been with us in Symbiosis also, and we know she is an invited and sought after faculty in several state, national, and international conferences. Madam has been a very efficient organizer. She is the organizing chairperson of Fem Power National Conference, which is a very successful show. She has been the chairperson of Ethics and Medical Legal Committee of Kasoga 23 to 25. She is rather South Zone Coordinator of Foxy Medical Disorders in Pregnancy Committee 24 to 25 and the Executive Committee member of Karnataka branch of ISAR 23 to 25. She has been the chairperson of Infertility and ART Committee of Kasoga 20 to 23. That's a special area of interest. South Zone Coordinator of Foxy Infertility Committee 21 to 23. Founder of EC member, Karnataka branch of IFS 19 to 23. Life member of several prestigious societies. Peer reviewer of Jogi. Past member of Foxy Sexual Medicine Committee, Endocrinology Committee, Food and Drug Committee. Joint Secretary Abhigyan. Foxy FIGO CEPHOG BSOG International Conference. Awards at more than 25 felicitations. Ex-PG teacher at MS Ramaiah Medical College and Bangalore Baptist Hospital, with several original articles, case reports, and poster presentations in the prestigious ESHRE conference of 2021, and more than 100 radio and TV talks, 100 camps, 40 newspaper articles, everything dealing with women's health. So welcome, Rekha ma'am. We would be honored to have a few words from you, ma'am.
Yeah, thank you, Dr. Monica. You read my CV so completely, so elaborately. Thank you so much for taking so much time on me. First of all, I should place my gratitude and thanks to you for selecting me as a special guest for your such a special program. I'm always in love with your programs, be it Symbiosis or Synergy programs. The flyers itself are so colorful. The logos are so colorful, and the name itself is so divine name, like the Synergy, Symbiosis means that we are all moving together. Like you always want to take people together with you, attach yourself to so many other societies, and along with you, you take so many people forward. You're so academically vibrant. Thanks for involving me in your programs. We are otherwise also the coordinators in our medical disorder in pregnancy, the Foxy Medical Disorders in Pregnancy Committee. We do the programs together. I'm happy to share the platform with Dr. Anju Soni, and the guests of honor are my again close friend Dr. Archana Dwivedi and Rashmi Kahar. Both are my good friends. The webinars have made us globally across. We all are knit together now because we meet in so many platforms together. You have associated yourself with so many societies, as you have already mentioned. You are the taskmaster and you know how to take the things forward. And you are the woman behind this great show, Dr. Monica. The topics what you have selected are also wonderful, and the speakers are also wonderful. You have touched upon very, very important topics. PPH itself is a very important topic, as all of us know, in spite of reading, learning, doing the courses and do it yourself courses also, sometimes we are caught unaware because we hardly have any time to manage that woman. So it is better we learn more about these things. Other than the PPH, you have again touched upon the micro topics of PPH, like the prevention, the perception and management, the stepwise devascularization and obstetric coagulation, the hemorrhage and coagulation. So you've almost touched upon everything under PPH. The as you said, the PAS, syndrome has become more common nowadays because of our repeated curettage or because of the Asherman's clearance. More than anything, it is our previous cesarean section. So it's very important for all the obstetricians, especially the newcomers, to know right on in the first scan itself whether the pregnancy is sitting there in the sac. They should have that idea, like where the sac is, where the fetus is growing. If they don't know, they will never have any idea about it, about the past, and they cannot be caught unaware in the last minute, because in the managing these kind of past syndromes is very, very difficult in smaller places like nursing home. You should be so well prepared. Yeah, thank you so much for involving me. And I wish you a very great success, not only in this conference, not only in your future academic programs, in your entire life ahead with your beloved partner. Thank you.
Thank you so much
Nice to
for
see you.
for the
Thank you.
beautiful message. You are
Thank you.
always so generous with your messages, Rekha ma'am. And you are a beautiful person inside out that we can see, and I have seen so far. And now I would like to invite our chief guest for today. I'm very, very sorry for the inconvenience you had, Anju ma'am, in joining. But our sponsors follow some protocols so that you know that information and the data comes to us by AI. So, so all the data of all the people registered is recorded, and then we have a database of all the people who are joining us. I'm so sorry for the inconvenience, and it is my extreme honor and pleasure to introduce before you the golden lady. I call Anju ma'am the person with the golden touch. Like everything she touches turns into gold. That I have seen.
Midas touch and great
Yeah,
leaders.
not only
Does
teaching,
touch.
but in academics, her programs, her conferences, whatever she does has got a special and very royal touch. And she recently, Madam was before the elections results came out, Madam was in Bhopal. We saw her face to face, how passionate she is about everything she does. So it's my great pleasure to introduce before you the Vice President-elect of West Zone FOXI 2026. Madam has won with a very huge number of votes from people who loved her from all over India. Madam is also the dynamic president of the Indian Menopause Society, which is growing vibrant and more active day by day. So, Neetu, you have to connect with Sheila Mane ma'am immediately, please.
Thank you, Monica dear.
Yeah,
All
ma'am,
your-
ma'am,
Yes.
just 2 minutes, ma'am, 2 minutes. Madam was the Secretary General of IMS. Madam is the Governing Council member of ICOG 23 to 25, member of India CCM 22 to 25, and chairperson of HIV and AIDS Committee of FOXI 22 to 23. Madam has held all the important posts possible, and I have seen the Poise magazine. She's the editor of Poise magazine. I also wrote articles for it. It's so beautiful, this manuscript, and it gives everyone an opportunity to write, to express themselves. We have this beautiful program every Sunday called Dancercise, which Madam has literally everybody dancing to her tune. And Madam is also a very great clinician. She is the HOD of the Sony Group of Hospitals, Jaipur, the Pink City, has been awarded several great awards like the IOG Excellence Award, Illuminous Alumni Award from the CM of Rajasthan, Chikitsa Vibhushan by the Health Minister of Rajasthan, Dr. Meru Dara Hansotia Award for Best Committee for HIV/AIDS in 2023, Appreciation Award for Unwavering Commitment and Dedication by NACO. Madam is also active in IMS. We can see how many IMS activities she has held. NARCHI. She has been awarded the Excellence Award for Women Healthcare by AWA. Beti Srishti.
Bus, Monica, bus. Thank you.
We are thrilled to have you as a chief guest.
Thank you, dear, for your generous, lovely, and beautiful introduction. I am really overwhelmed with your love and affection. And at the offset, I would like to congratulate you for creating this beautiful series, which is so practical and essential. And it's my honor to address all the esteemed gathering who have been there today. And I'm particularly delighted to acknowledge the presence and support of our partner societies, Bagalkot, Bidar, Chitradurga, and Gulbarga. Welcome to all of you, dear. Your collaboration is definitely instrumental in expanding the reach and impact of today's discussion on maternal health. And before I begin, I would like to acknowledge our distinguished speakers today, Dr. Sheila Mane, a dear friend who will be addressing a very, very important topic, the PPH prevention and perception and management. Dr. Mitra Saxena, another very good friend of mine, speaking on rationales of stepwise devascularization, and Dr. Nalini Mishra covering the critical topic of obstetrics, hemorrhage, and coagulation. All the topics are at the heart of obstetric practice, particularly in managing the life-threatening complication of postpartum hemorrhage. And I look forward to enriching discussions with insights from all the distinguished speakers. When we talk of PPH prevention, it remains that we all know that PPH remains a leading cause of maternal mortality globally, with an incidence of 1 to 5%, and it's more so in the developed countries. And it is in the vaginal, even higher in the cesarean section. The standard definition of PPH is, we all know that 500 ml falling vaginal and 1000 ml after cesarean within 24 hours of birth. While this absolute value approach has limitations, but it gives us a variability in individual patients' hemodynamic tolerance, and it remains crucial to standardize the assessment. So prevention begins with thorough risk assessment during antenatal care. Known risks such as multiparity, uterine overdistension, prior cesarean, I just now discussed, coagulation disorder, all should be identified during the antenatal period. And we must use prophylactic uterotonics. Particularly, we all know how oxytocin is there to reduce PPH by active management, and it has been found by WHO recommendation that up to 60% cases by single intravenous or intramuscular injection of 10 units is more than enough. And oxytocin immediately post-delivery will also can be given, when it is forgotten at that time. And recently we have carbotocin in our armamentarium, which is an analog of oxytocin. It may provide a superior prophylaxis in preventing atonic PPH, particularly in high-risk patients going through cesarean. Misoprostol is also there, an alternative second-line therapy and particularly in resource-limited settings where oxytocin may be unavailable or impractical due to cold chain requirements. However, prevention goes beyond pharmaceutical inventions. The perception of PPH, how we anticipate, respond to it, how quickly we respond to it is very, very vital. In the settings where the maternal mortality is high, the psychological and emotional stress surrounding childbirth and its complications must be acknowledged by all of us humanly. And women who may harbor significant anxiety regarding their childbirth experience, particularly when they're aware that of the PPH risk. So clear communication is very, very essential between the healthcare provider and the patient, ensuring that they understand the precaution being taken contributes not only for their psychological well-being, but also for overall compliance and care recommendation. It is fundamentally early recognition and rapid structure intervention. So we all know what 4 T's are: trauma, tone, tissue, and thrombin. It remains a cornerstone of diagnosis. Uterine atony has to be prevented because it accounts to almost 70 to 80% cases, and of course we have many masters sitting with us talking about Bakri balloon and all other manual. So I'm not going to go into talk about that, but yeah, we must rule out lacerations, uterine rupture, placental fragmentation, and coagulopathies well in advance. And of course, point care with us is to have an ultrasound to us help us, and of course lab-based coagulation panels. Then coming to devascularization, when all above are not suitable, we must shift to the second step, that is rational of separate devascularization, which my dear friend Mitra will go into detail, because timely done, this procedure is a we'll call it a very important technique to maintain the hemorrhage, uterine integrity, and crucially for the future fertility bearing. And we know that when we talk of the ligation of sequential ligation, we reduce the blood flow to uterus without requiring immediate hysterectomy, bilateral uterine artery, ovarian artery, and then hypogastric arteries and internal alike are the options available with that. But the term of success rate and studies shows that in almost 60 to 75% cases, we can control refractory PPH with medical management, and then rest we can go through this devascularization, and we can prevent purpurium hysterectomy in a big way. And in some cases, if we need to do hysterectomy, we must do to save the patient, and it is very important. And wherever in a good center where uterine ambulation and other hemostatic agents are available, we must go through those also. We know that coagulation is a very important part of PPH, and it is very important to know about. We know that with little hemorrhage, more than the amount required, patient can immediately go into consumptive coagulopathy, and there is where we need to immediately talk about the patient's DIC, and it is especially a very realistic condition, as it results from both thrombosis and bleeding due to systemic activation of clotting cascade compounded by factor depletion. And once hemorrhage surpasses 15 ml, the transfusion protocols must be enacted, including massive transfusion protocols with the balance of red cell and plasma and platelets, the ratio of 1:1:1. And then, of course, concentrate and cryoprecipitate early in the resuscitative efforts are very important. Given in time, it can prevent patient from massive hemorrhage. And of course, our tranexamic acid is again very good to control, prevent fibrolysis. And women trial is about how significant we can give tranexamic acid within 3 hours of PPH onset and can reduce mortality up to 13%. However, we are knowing that vasoelastic testing, that is thromboelastography, has become an increasingly important guidance for transfusion therapy, and the products given like fibrinogen, plasma, platelets are very essential. So we must percept in early, and I want to congratulate all the speakers, the guest of honors, Dr. Archana, Dr. Rekha, for coming together for this such an important webinar today, where I'm sure the organizer, Dr. Monica, will definitely delve deeper in for everybody's benefit. Thank you very much.
Thank you so much, ma'am. Thank you, Anju ma'am, for that beautiful description of the talks which are going to happen shortly. And we are honored to have you, ma'am. And we would love to, if you could stay in our program and watch our talks and see and discuss with the speakers. Next, it is my pleasant duty to introduce my guests of honor. They are my two beautiful friends, Dr. Archana Dwivedi, who is President Baroda OBGY Society, and Dr. Rashmi Kahar, who is President Amravati OBGY Society. Both of them are very dear to me, but Rashmi could not join because Amravati Society has got some program going on. So Archana has got, is keeping the banner of Synergy high, and she has always stood by me She has recently won the most coveted post of chairperson-elect of Midwife Committee. Applause to you, Archana, for that closely contested election in which you shone like a star. She is also, a very prestigious post she has held.
I'll stop
Yes,
here.
I would just like to mention that you are not only active in Baroda OBGY Society, but also in IMA, and you have worked very hard in the Menopause Society and been there everywhere I've seen you, whether it's Prayagraj, the National IMS conference. Recently, you had a very beautiful conference in Baroda itself. That FEM conference, was it, Archana?
It was WWW Holistic Women Wellness
Yes,
Conference.
yes.
Dr. Anju Madam, we had the honor to have her also with us.
You have been a Dhira master trainer, HP vaccination. So we are really honored to have you, Dr. Archana, and we would like to have a few words from you, please.
Thank you, dear Monica, my dear friend. And I think the elections has brought all of us so close and so together. Rekha ma'am, you and me go along so well with guidance of Dr. Anju Soni ma'am. She has been constantly with me during my IMS tenure, which is still going on, and sharing the platform with stalwarts like Midra Saxena madam, Sheila Mane madam, and I mean, so many Nalini Mishra, madam, and all the four society stalwarts, they are themselves a learning experience for all of us. So I would like to say only that you have taken up a very apt topic, which Anju madam has described so nicely, that people are choosing between family and career. So I think the midlife problems are going to stay, and so is going to come the problems associated with pregnancy. Pass is one. There are other things also, more interventions, more procedures, and late planning of pregnancy. These are all circumferential, I would say, holds responsibility for taking good care of our motherhood. And Sheila madam, we call her as a PPH lady, and I feel very fond because I've worked with her. Nidra Saxena madam was here off late at WWW conference. And Nalini Mishra madam, I'm looking forward to hear, because obstetric collapse is something which is going to be a cutting edge era, which we are already stepping into that. Initially, we used to feel that only rural public is responsible for coming because they are malnourished, ill treated. But let us take a backlog and see now the urban population who is busy in working in corporates, they are coming with more and more problems because Google driven, very hard to be counseled sometimes, but these are going to lead the problems in future. So I feel very apt. Before I talk further, I would like to share a case where the patient went to the sonologist for a sonography in a peripheral area. She was already admitted for 7 to 8 days for the pain and abdomen. Sheila ma'am, you would be shocked to know that she has obstetric collapse over there, then and there. And since I'm sitting at a tertiary care center, Monica, she was brought to me. And since she was a case of previous cesarean section, we thought must have been perforated from there. We had no choice to resuscitate her, give her all the blood products, everything what madam has talked about, took her up into the OT. It was a IUFD, and it was placenta percreta perforation from the posterior uterus at the age of 28 weeks of gestation. So I think we need to introspect, and with the symbiosis energy, the topic which you have chosen is very apt, as I'm very young to say that, with people whom I have been learning from are sitting in front of me. But I feel that we have to introspect that this is going on rise. And if we take a proper ultrasound at 10, even 9 to 10 weeks, we have an idea of what we are going to have in future. So thank you for involving me. It's my pleasure to be in the platform, to listening again and again to all the three stalwarts as a learning experience. And with Anju Soni madam, everybody out here, thank you for involving me on this academic platform. Monica, we'll stay together anytime you need. Thank you so much.
Thank you, Archana, for always being there. And I'm really grateful to you for your kind words. And at the outset, before we start our academic program, I would like to extend my deep, deep thanks and gratitude to respected Dr. Sheila Mane ma'am, Dr. Mitra Saxena ma'am, and Dr. Nalini Mishra ma'am for making our program what it is. It is not the program, it is you, your presence, which has led the brilliance to it. So I now thank my three coordinators. Can I have their pictures, please? We should know who is at the helm of the things. So these are the three beautiful gynecs, young gynecologists who are, holding synergy together with me since many, many months, over a year. That is Dr. Neetu Mishra from AIIMS Bhopal, Dr. Purva Bhatkur from GMC Bhopal, Dr. Nandini Singh Bhati from GMC Bhopal. All the programs which we put together, which we coordinate, the topics, how they align with each other, how the speakers are contacted, how the chairpersons are decided. Each person should be contacted individually. There should be no negligence at all. Everybody has to be present during program, and we have to announce the next date also. All this is done by these three great ladies. Thank you so much, Neetu, Purva, Nandini. And now I hand over the program to Dr. Neetu to start the sessions.
Thank you so much, ma'am. And it's my proud privilege to be a part of Synergy webinar. And to start with, I just want to say a few words about Synergy. Synergy technically means it is a combined effect of a group of elements greater than the sum of individual effects. And in our webinar, we are focusing mainly on that. The power of collaboration with different speakers, the stalwarts of the different fields, and the potential for greater outcome through the combined efforts of our faculty as well as our whole team. So this is the essence of our Synergy webinar. And in this third series of this Synergy webinar, we have come up with the very important topic, that is postpartum hemorrhage, one of the number one cause for the maternal mortality in India. So now we will move ahead for the scientific session. In the first session, we have speaker none other than Dr. Sheila V. Mane Madam, ICOG Vice Chairperson. She will be talking about PPH prevention, perception and management. To chair this session, we have equally efficient chairpersons. Dr. Anjali Kanhere Madam, she is past President of Bhopal OBGYN Society. Dr. Lata Venkateshan Madam, she is consultant at Sundaram Medical Foundation, Chennai. And Dr. Hema Sinhasane Madam, she is President of Gulbarga OBGYN Society. Dr. Anjali Kanhere Madam is the past President of Bhopal OBGYN Society and Professor and Head of the Department at Chirayu Medical College, Bhopal. She has many awards in her bag. She has
Dr.
won...
Neetu, you can just skip it, please.
Just ma'am, one line. She has won the Best Professor in Obstetrics and Gynecology Award in 2023 by World Education Congress. And we are honored to have you, ma'am, as chairperson for this session.
Thank you so much.
Our next chairperson is Dr. Lata Venkateshan Madam. She is consultant at Sundaram Medical Foundation, Chennai, and she is affiliated there for last 2 decades. She is alumni of prestigious Madurai Medical College and Madras Medical College and has vast extensive experience in clinical obstetrics. She is also has special interest in high-risk obstetrics and holistic obstetrics. And we are very honored to have you, ma'am, on this session as chairperson.
I like to thank you, Dr. Monica Singh and Dr. Neetu Mishra, for having me in this successful program. I think I have been wrongly called because I am proud to be here among these stalwarts, and I am honored to chair this session where Dr. Sheila Mane Madam is speaking. Thank you.
Madam, you are very, very much welcome, madam. And we should have and we would have called you anyways, ma'am. There was a little error about the society. We are very sorry for that, ma'am. But you are more than welcome, ma'am. We are so honored to have you, ma'am.
Yeah. Thank you. I belong to Oxy, Chennai, Southern India. Yeah.
Yes, ma'am.
Okay.
Rather than accident, this was a destiny, madam, to have you.
I think so.
We are so much privileged to have you, ma'am. And our third chairperson for the session, Dr. Hema Sinhasane Madam. She is very senior obstetrician at Kalburgi, Gulbarga OBGYN Society. She is president of Gulbarga OBGYN Society. And we are very honored to have you, ma'am, as chair of this session. Now I hand over the session to our chairperson.
Thank you, madam. Good evening, everyone. It's my proud privilege to introduce Dr. Sheila Madam. Sheila Mane Madam was here in Bhopal for our conference, and recently I have met her, and I know her as a very passionate teacher. She was all with the PG students, and PG students were literally hovering over her to see whatever she was teaching. And today, when I told my PG students that you should attend this session, they said, yes, madam, we are going to be there because we know how great teacher madam is. Nalini Mishra madam is from Bhopal, so I know we have had many personal sessions with her also. And again, Dr. Mitra Saxena madam was there in the conference, in the workshop, and she also demonstrated the devascularization very well. So I'm sure the program is going to be a great success, Monica. Thank you for having me over. And it's my pleasure to introduce Dr. Sheila madam. She's ICOG Vice Chairperson. She's Vice President Foxy 2014. She was Chairperson of Safe Motherhood Committee, President of Bangalore Society, President of BMS Bangalore Society, National Facilitator Adolescent Health, ICOG Governing Council member, ex-President of Bangalore Menopause Society, President ISOPAB Bangalore. She's being a reviewer of Jogi, our journal, and she's a faculty of FIGO PPH simulation workshop. And I think Madam needs to upgrade her CV with being the ICOG coming up president, if I'm right. So it's
I'm the vice chair currently. 26, I'll be the chair.
yes. So Madam, that has to be included as elect for 26.
Yes. So next year, no problem.
Yes, ma'am. Thank you so much for being here, madam. And the session is all yours.
Yeah, I still thank you, Dr. Anjali. I also still have the fresh memories of my Bhopal visit and that workshop. And afternoon, I know that the drills arrangement was done, which was really very excellent. I think your skill lab is very good. In that medical college, and I really acknowledged it. That was really
thank you
nice.
so much.
Thank you for the invitation. Yeah, and nice to see all my colleagues from Karnataka as well as Dr. Lata from Chennai. I think this is a South and West amalgamation. Okay, Dr. Rekha, our president, is there. Gulbarga, Chitradurga, then Bidar, Bagal.
We wanted, man, this time we wanted we had focused on South Zone, but ultimately it became Karnataka only. There are so many societies in Karnataka.
Societies. So it's nice, I think through webinar. Thank you. Okay, so I will start my talk. Thank you very much. Can I share my screen?
Yes, ma'am.
I can start sharing.
Yes,
Thank you, Sheila madam. Nice to see you.
Thank
here.
you. There. All of us are there.
Yeah.
Bhopal, many times I have gone and done this PPH.
Hello, ma'am. Nalini here.
Yeah, hello, Nalini. Again, we are now twins in PPH. Okay, so prevention and preparedness, like everybody was talking about this, and all of us, we know that preparedness still plays a very big role as today the scenario is changing. So I think it's very important that we are prepared. Otherwise, we know that we can still face problems. So it affects approximately 5% of all birthing women, still the leading cause of maternal mortality in most low-income countries. And it is estimated that there are 10 near misses for every maternal death due to PPH. And that is very important because the near misses also should not be missed because they will need a lot of attention. So it is very important to improve the clinical skills and knowledge of the risk factors of PPH because they are instrumental in preventing the maternal morbidity and mortality. All of us are aware of the goal of WHO to reduce the global, and that is SDG goal, maternal mortality ratio to less than 70 per lakh live births. And all of us, we know that South, we have achieved it. Still, I must say that Karnataka has to still do a lot compared to other states. But I would like to see this scenario all over the country. I think then only we can say that we have really achieved. Because if we go state-wise, the scenario is different. Now, these are the common preventable errors. Okay. So these errors are under recognition of the blood loss. I mean, why we are still facing problems? Lack of appropriate attention to clinical signs of hemorrhage and associated hypovolemia. Failure to act decisively with life-saving interventions. Means once we have diagnosed, we have to be taking the decision very fast, and failure to restore the blood volume in a timely manner. So these are the errors which we are facing nowadays, and these will help us to prevent. Now to this August gathering, I don't have to talk about PPH, but the standard definition is blood loss of more than 500 ml in vaginal delivery and more than 1 liter in cesarean. Primary PPH, which occurs within 24 hours of delivery, and uterine atony still remains the most common cause. Secondary PPH is from 20 hours to 6 weeks. And massive or severe PPH is defined as a blood loss of more than 1000 ml or more within the same time frame. Now, we can divide PPH as minor, major. Major can be divided into, again, moderate, where 1000 to 2000 ml is the blood loss, and severe, where it is more than 2000 ml. Now, for clinical purpose, any blood loss that has the potential to produce hemodynamic instability should be considered as PPH. And I think in low-income countries, this plays a very big role, because, you know, people will always underestimate. And I mentioned in the clinical errors that is one of the error. So clinical judgment will always help us to assess the hemodynamic state of the patient. Now, massive obstetric hemorrhage is variably defined as a blood loss from the uterus or genital tract of more than 1500 ml or at the rate of 150 ml per minute, or 50% of blood volume lost within 3 hours, or decrease in hemoglobin of more than 4 grams per deciliter, or acute loss requiring more than 4 units of packed cell transfusions, or any hemorrhage associated with hemodynamic instability. All of us are aware of these 4 T's. Uterine atony, the most common, sorry. Responsible for 70%, then tissue, retained placenta and clause 20%, trauma, vaginal, cervical or uterine injury 10%, and coagulopathy less, that is 1%. So if we look at the causes under these 4 headings, in tone, there could be a history of previous PPH, multifetal pregnancy, grand multifetal macrosomia, polyhydramnias, failure to progress in second stage of labor, prolonged third stage of labor, even fibroids we see nowadays, and general anesthesia. In trauma, operative deliveries and perineal lacerations and episiotomy, tissue, retained placenta, and one more is added now is the adherent placenta, placenta accreta. Thrombin, it could be associated, DIC associated with preeclampsia, HELLP syndrome, or if the patient has bleeding disorder, sepsis, or if she is on drugs like aspirin or heparin. Now, when we look at this management, there are 3 broad areas in which the outcome of PPH may be improved. That is prevention, treatment, and rescue. Now, prevention covers antenatal strategies, so that then the active management of third stage of labor and treatment for retained placenta. And PPH treatment covers both medical and surgical, and rescue therapies include IV fluids, blood transfusion, coagulation correction, and support tube care, such as compression garment or even balloon tamponade. So if we look at this histogram of blood loss at delivery, showing the death zone at a loss of over 40% of blood volume, and the 3 strategies for intervention, that is prevention and treatment, can definitely prevent this 40% of blood loss, because the patient will go into death zone. Okay, so it is very important, prevention and treatment. Now we have to look at the prediction and the risk factors. So antenatal risk factors, I already discussed, but still previous PPH or retained placenta, not retained placenta here. Maternal anemia is a very, very important thing. Maternal age more than 35, we are seeing many elderlies coming. Body mass index more than 35 kilogram per meter square, we know obesity is common. Grand multis, antepartum hemorrhage, overdistension of uterus, and pre-existing uterine anomalies. We also have to look at the risk factors in labor. That means when we are talking about prediction and prevention, we are looking at antenatal. Then as soon as the patient is admitted again, whether we have done induction of labor, look at the stages, prolonged first, second or third stage of labor, secondary arrest of labor, especially in multigravidas, use of oxytocin may be injudicious, precipitate labor, and operative delivery or cesarean section is also the cause for PPH, because if we look at the incidence of PPH, it is more. It is almost 4 to 6% with cesarean. So a patient safety bundle we have to look at is a set of straightforward evidence-based recommendations for practice and care processes known to improve the outcomes. And this consensus bundle on obstetric hemorrhage is organized into 4 action domains: readiness, recognition, and prevention. Then comes the response once we have diagnosed, and reporting and system learning. And there are 3 key learning elements within these 4 action domains. Now, readiness, yes, every unit. We have to have a hemorrhage cart with supply, checklist, and instruction cards, even for intrauterine balloon and compression stitches, because people may not be aware how to do that. And if these are kept, they can do it. Immediate access to hemorrhage medication. So you should have a PPH drug kit, which is ready. Establish a response team. That is who to call when help is needed. For example, for the blood bank, you may require a advanced gynecological surgery. So you may require an onco surgeon. Suppose if you have to do internal iliac artery, if the person is not trained, or other support and tertiary services. And we have to establish massive and emergency release transfusion protocols. For example, if you are in a tertiary care, you are receiving cases like just now how Dr. Archana explained, you have to have a type O negative blood, or you may have to even give an uncross match same group blood, because the patient is in a class 4 hemorrhage. So, and the unit education on protocols and unit based drills will is very important, because what happens is then during drills also we can see what went wrong and what went right, and the debriefing can be done even during the drills. Recognition and prevention, in that again, assessment of hemorrhage risk, again prenatal on admission, measurement of cumulative blood loss, formal as quantitative, and active management of third stage of labor, again for every patient. Response. Every hemorrhage, you need a standard stage-based obstetric hemorrhage plan with checklist has to be ready, and support program even for patients, families, and staff is required. Reporting and system learning, we have to establish a culture of hurdles for high-risk patients and post-event briefs, multidisciplinary review of serious hemorrhages for system issues. For example, we'll have to look at each and every aspect, and we have to monitor the outcomes and the process metrics in perinatal quality improvement, because if we do, then only we will be able to improve. Coming to readiness, again, the readiness domain includes 5 areas of focus to be addressed by every facility to prevent delay and prepare for the optimal management of obstetric hemorrhage. Readiness aims at improving interdepartmental coordination. So it's very important. Hemorrhage cart, all of us, we know that along with other things, we should also have the drugs kept. And I would like to add to this now, that is carbetocin as well as your tranexamic acid. Surgery, for example, it could be traumatic PPH. So we should have a vaginal retractors, long instruments like needle holders, scissors, Kelly's clamp, sponge holders, intrauterine balloon, or a bungocurate, bright task light, and procedural instructions. I'm again saying, cesarean laparotomy, we should have a hysterectomy tray ready, all the suture material, reloadable straight needles. If you are taking a different suture, a larger needle for B-Lynch. Again, I'm saying intrauterine balloon in OT also, and procedural instructions like for balloon, B-Lynch, and arterial ligations. Now, when we are doing this, we have to establish the readiness. So determine who will be the part of your core response team, primary maternity care provider and nurse, clinicians from even anesthesiology, transfusion service, pharmacy, advanced gynecological surgery, critical care medicine, main operating room, interventional radiology, additional nursing resources. So readily available phone or phone numbers, or a rapid response, or a code system. I feel we should always have all of us have to really decide that we should have a code for PPH separately, as it is so common and you don't have much time. Okay. And you will have to establish massive and emergency release transfusion protocols. So protocol facilities rapid dispensing of RBCs, plasma, platelets in predefined ratio, because what we follow is 1:1, which intended to preclude the development of a dilutional coagulopathy, because that can result if a significant percentage of the patient blood volume is replaced with large quantities of crystallite, colloid, or RBCs. So what we have to learn is, yes, we have to give IV fluids till the blood arrives, but not more than 2 liters. Meanwhile, if it is a massive blood loss, class 3, class 4, we have to get the blood and blood products immediately. Now, as volume is replaced, attention must be paid to coagulation parameters, platelet count, and metabolic status. You will have to check for ABG. Now, we don't have any national guidelines for activating the massive transfusion protocol. The criteria are varied and include when patient is actively bleeding are of the following: systolic blood pressure less than 90 millimeters of mercury, pH less than 7.1, base deficit is more than 6 milliequivalent per liter, hypothermia, INR more than 2 means your patient has gone into coagulopathy, and platelet count less than 50,000 millimeter cube. So blood bank, we have to tell to issue in this case 6 units of FFP, 6 units of platelet, and 10 units of cryopreset, because already there is a afibrinogenemia. So if we say now, when we say 1:1:1, nowadays with massive bleeding, we would also like to add cryo. Why? Because cryo will give you more fibrinogen. Okay. Now, when there is a hemorrhage, we can also conduct the drills in our department. I mean, not when there is a hemorrhage, but to train the staff. And what is drill refers to clear and logical set of steps involved. All team members are familiarized with the entire safety bundle and new management plan. Participating members are assigned the tasks and responsibilities necessary to run the drills. And post-drill debriefing provide an invaluable opportunity to learn from the experience, specifically to enforce the areas of the drill. I already told that went well. Discuss areas in need of improvement, share lessons learned, and highlight the system issues to allow for concrete planning for potential solutions. Drills may be combined with practicing infrequently used hemorrhage technical skills like placing a tamponade balloon or a compression suture using simple aids. Again, recognition and prevention, assessment of hemorrhage risks, that is identification of risk, help to improve the readiness, increase surveillance, early recognition, increases the use of preventive measures, and prepare the team to initiate an early aggressive response to bleeding. And risk assessment should be considered at multiple time points during patient care, including antepartum, on admission to labor and delivery, and late in labor. That means patient is in labor, you will have to go on assessing her again and again. Now, the vital parameters, all of us, we know that we have to monitor them, and you will find that there is a worsening tachycardia or a mental status is altered if the blood loss is more than 1,500 ml. Rule of 30, where there is a fall of systolic blood pressure of more than 30 millimeters, increase in the heart rate by 30 beats, urine output less than 30 ml per hour. That means the patient has already lost 30% of whole blood, means she is in class 3 hemorrhage. And shock index, if it is pulse rate divided by systolic blood pressure, if it is more than 1, it indicates that your patient is in shock. This is the chart, and we should have this type of chart. Now, it is very important, shock index. Why it is important? Because if you look at this chart, the class 1 and class 2, not much difference in the hemodynamic status of the patient. But if we do the shock index, you will find that your patient is definitely bleeding or she has lost blood, because normally during pregnancy, the shock index is 0.7 to 0.9. Once it crosses 9, that means your patient is in hypovolemia. If you have 30-40%, her shock index will be 1.2. And you can just see even the capillary refill. Okay. And in later stages, you will not have time. Immediately start the crystallite, big bore cannulas on both the hands, monitor all the vitals, and get the blood and blood products immediately. So, risk assessment, once again, prenatal, suspected previa, accreta, increta, more BMI, if she has a bleeding disorder, and other significant medical and surgical risk. Now, medium risk is what? Prior cesarean, uterine surgery on admission. This is multiple laparotomies or even prenatal. And we discussed this: multiple gestation, multiparity, prior hemorrhage, large baby obesity, and if she is anemic. High risk, placenta previa or low-lying placenta, suspected accreta, percreta, platelet already less than 70,000 will become, because if she has HELLP, active bleeding, known coagulopathy, and if you have 2 or more of a risk factors, then it becomes a high risk. So we have to decide whether we can manage or we have to refer to a tertiary center. Intrapartum, medium risk chorioamnionitis, prolonged oxytocin given for more than 24 hours, prolonged second stage, if the patient is on Maxel. High risk, if there is a new active bleeding, or 2 or more median risk factors, either on admission and or even intrapartum. Now, measurement of cumulative blood loss plays a very important role. So visual estimation of blood loss, a glance and gaze is a common practice where we try to underestimate by 33 to 50%. So direct measurement of blood loss can be accomplished by 2 methods, which are complementary. Easiest is to collect the blood in calibrated underbuttock drapes for vaginal birth or in calibrated canisters for cesarean birth. Second is to weigh the blood-soaked items and clots, and the weight of dry pads is subtracted from the total weight to obtain an estimate. And I think all of us have to really make it a habit so that even our PGs, everybody starts learning this. Now we can have these type of charts in labor room where we have these swabs. Even during episiotomy, we use so many swabs. So a small swab, 10 into 10 centimeter completely soaked is 60 ml, medium is 140, large, if we have, is 350 ml. 1 kg soaked swab itself means 1000 ml blood loss. Kidney dish full of clots, 500. Diameter smill also depending on centimeters, 50, 7500. It is 500, 1000 or 1500. And if the patient is bleeding and it is coming to the floor, definitely it is more than 1000 ml. Active management of third stage of labor, I don't think I have to explain here. I just say remember OCM. Oxytocin, control contraction, and massage. Now, this is the recommendation. All of us, we know about it. Coming to the response. Obstetric hemorrhage emergency management plan is critical issue. It's a critical step is to determine the etiology. And stage-based management plans have been found to facilitate an organized stepwise response to blood loss and maternal warming sign. So we should also have the MEOT chart where even the nurses know when they move from one zone to, and they are going towards amber and red zone, that they have to call the seniors. They ensure that resources are not wasted while each patient receives optimal therapy, and they have to, each institution needs to adjust the plan to meet its individual capabilities. So again, if it is stage 0, that is you activate the hemorrhage protocol and a checklist should be ready. Assess the risk factors, estimate blood loss, IMTSL should be done, and high risk, you will have to send for type and cross match. Low risk, you type and keep it ready. In class stage 1, advanced through medications and procedure, finding cause and treatment and visualization, you estimate the blood loss. You know there is PPH, immediately start big bore cannulas, give IV fluids, put the catheter, fundal massage, give more oxytocin, and give again additional oxytocin, and keep 2 bottles of blood ready, cross match. That is class 2. Stage 1. In stage 1, stage 2, you will have to tell the blood bank to send, keeping check of volume and blood products. Patient is bleeding, continuous bleeding, which can become class 3, class 4. You have given already the uterotonics. You will again draw the blood for your coagulation profile, even get the fibrinogen done. If there is a trauma, treat that. You can insert the balloon here. You have facility, go for UAE. If it is a cesarean, you have to inspect the broad ligament. You can decide which compression sutures you want to input, and you can also proceed with stepwise devascularization, which other speakers will do. And you will have to immediately give her 2 units of PRB. Okay, use the blood warmer. Again, you have to immediately ask the blood bank to send you 2 FFPs, and then you again give her 2 units of PRBC. Now, giving PRBC is very important because the patient oxygen saturation need to be maintained. So along with FFP and platelet, you will have to give that also. Once it is stage 3, you have to activate the transfusion, the massive transfusion protocol, which we already discussed. You get all the coagulation profile done again and start the central line. You will need a help of HD or ICU person. You have to decide now what supportive treatment you want to give, whether she needs surgical treatment or you have to correct her DIC before taking her for surgery. And you have to order the blood products in the ratio of 1:1:1. And I also mentioned about cryoprecipitate. I would also like to mention here now the fibrinogen concentrate is also available. Support program for patients, families, and staff. Women and their families need timely information, whether it is public or private sector. Now you have to give reassurance, and we have to give the opportunity to discuss the incidents with them and with the maternity care provider. Reporting and system learning, we have to establish a culture of hurdles and debriefs need to be routine, multidisciplinary review of serious hemorrhages. And the purpose of this review is to identify the system issues, whether we are getting referred cases, are they coming from one particular hospital, are they sending them always late, then we can involve these people, because we are at the receiving end. And the review should be sanctioned by the facility, yes, protected from discovery in legal proceedings, and include a thorough record review, event timeline, and focused root cause analysis. So we are looking at focused root cause analysis here. Monitor the outcome and process metrics. It's important for successful introduction of quality improvement projects. So the overall goal is to reduce the number of obstetric hemorrhage that escalate into major blood loss, resulting in severe maternal morbidity and mortality. If you look at the incidence of PPH in Asia, even though overall it is not more, but we have more cases of severe postpartum hemorrhage. And that is why our patients succumb. Now, these are the technical skills like UK have prompt. We were all trained once upon a time. So it is very important to improve their knowledge or standardize. Other courses include MOET, Managing Obstetric Emergencies and Trauma, even Advanced Life Support. Everyone in the labor room should know this. And evidence-based memory aids can be taught to facilitate recall of fundamental treatment steps in PPH. And they have shown to reduce the chances of peripartum hysterectomy. Important is the communication amongst members of the multidisciplinary team should also be emphasized. Obstetric emergency simulation training and non-technical skills will cover communications, teamwork, and leadership. So the patient is in the middle. We have to have the expertise, knowledge, and experience. For that, situational awareness plays a very important role. So communication skills and understanding of team members, multidisciplinary team, which we discussed. Infrastructure, yes. If we have an obstetric patient, means we have to have all these facility. Improve the knowledge by simulation. Go on assessing the patient antenatally as well as intrapartum. Prevention and management, all of us have learned about this. Okay. If home birth, I will not talk. I think it is not happening anymore, but maybe in certain areas, and we know that we don't have TBS now, but we have empowered our ASHA workers with misoprostol tablets. So if there is anybody who is delivering at home, at least she can give her 3 tablets of misoprostol. And depending on this facility treatment, whether you are a CSC or district hospital or regional hospital, we will have to treat the patient. Whatever it is, resources matter a lot, and resuscitation is very important. If we are at a periphery, I think introduction of balloon should be taught to them, application of non-pneumatic anti-shock garment, it must be there everywhere. And the other methods, whatever we can do, immediately control the bleeding. So do bimanual compression, aortic compression. Yes, we are giving oxytocin, okay, if required, manual removal of placenta, and balloon tamponade can be used. That is at CSC. If it is a district hospital where the operation theater is available, after the fluid resuscitation, we have given the blood transfusion, then we may have to give inotropes if she is in shock, and BMOC treatment, plus we will have to give all other oxytocin, traumatic PPH to be managed, and you may have to proceed with laparotomy. And if you are at tertiary center again, okay, hospital, in that case, we may have to give her massive transfusion. Now, all of us, we know about carbetocin. I have acknowledged even the UNICEF work in Madhya Pradesh, where 20,000 patients received this drug and where there was no mortality. So I think, I wish that government brings this in the guideline which all of us have to really enforce and see to it that we use this. All of us are using. Once again, about non-pneumatic anti-shock garment, it should be available in each and every facility, whether it is periphery, CSC, PSC, private hospital, medical college, or even a tertiary care center, because you can really divert the blood to the vital organs, and the patient blood pressure can be brought up by even 20 to 40 millimeters of mercury, and you can even wait for the OT to be get ready in case you waiting for the OT, then also you can apply. So it is recommended not only for low research, but even everywhere it can be used. Okay, so these are the steps for the application of NSG. You are aware, I think everyone is aware in Madhya Pradesh, I think it is available also. And if we have to do a laparotomy, then we remove the first, we don't remove the first, second, and third, remove only the pelvis, the abdominal segment, and proceed with laparotomy. So this was just a small question. A capillary refill more than 3 segments or absent, designate what class of hemorrhage and what percentage of blood volume. This is for the PGs, for brainstorming. Just think about it. Thank you very much for your patient hearing. And myself and Dr. Shobha Gudi have edited this book. It's very concise one, but gives a very important information. So I would like all of you, if you can, it is from JP Publications. Thank you. I would like to say an ounce of prevention is worth a pound of cure, which was said by Benjamin Franklin. And I think it applies to postpartum hemorrhage also. So thank you very much for your patient hearing.
Thank you so much, ma'am. Thank you. Chairpersons?
Madam, it is an excellent talk. It included every aspect of PPH. Postpartum hemorrhage is a nightmare to every obstetrician. As Madam has said, however much we are experienced, preparedness is very important. And managing effectively and keeping the patient alive is a challenge. It needs a lot of courage, skill, and facility. That's how we can reduce maternal mortality due to PPH. Madam has rightly said the preparedness is very important. Then communication to the place where the people refer. That is also very important. Excellent talk, Madam. Thank you.
Thank you. I mean, I go to every state. I must tell you that Tamil Nadu is the state where there is a NSG in every public facility.
Yes.
No, Dr. Lata, it is available in PSC, CSC, medical college. Not only one, they have two. So if they refer the patient, and they get the replacement unit from the other hospital. So they
Yes,
have a structured program. Even the ambulance also has. Okay.
Yes.
So in case of an emergency, and all of us, we know the success story of Tamil Nadu, the maternal mortality is so low. So it is very important, that I think Madhya Pradesh, we met your Dr. Dubey also. So I think we have to really take it further. Monica, if you are doing this synergy program, see to it that in Bhopal or in Madhya Pradesh, everybody brings it. Okay.
Yes,
And another thing I would like to acknowledge, anyway, Dr. Nalini is here. And I think everybody, all the health workers should be taught, because we know Wardha district, Dr. Poonam Shivkumar, she's practicing PPH bundle, where the healthcares have been taught to put the balloon tampon ad. Okay. And they have brought down, since I think 2 or 3 years, there is no death due to PPH. And their maternal mortality is only 16. So it is achievable in our country also. We can't say that we are low resource. I think we have a lot of resources now, but the training and the teaching from the periphery has to be done, seriously. And I think again with Dr. Coming President, we are going to work on this, and let us see that we try to reach to each and every state to see to it that we don't lose mother due to postpartum hemorrhage. I think that should be our goal. Dr. Hema is here from Gulbarga. So all of us, we will see that Karnataka also make it applicable. Thank you.
Very true, madam. Madam, after your beautiful talk, we have got.
Yes, yeah.
Madam, we have got the stark contrast of Tamil Nadu to MP, where we have got, less than 20 and more than 100. So that is worrisome, and that is a strong message that since we are organizing this program, it has to get across all barriers and we have to implement it. If there is going to be, implementation in the state, it has to go with the training. Thank you
And
so
you
much.
have everybody here, Dr. Anjali, such a senior professor, Dr. Nalini Mishra, and I think all of us have to work. And I
Yes.
think I wish to work for all the states to see to it कि वो जो 70 वाला है ना, वो सभी states में होना
Achieve हो
चाहिए. Then
जाएगा.
only we can say that we have achieved. Otherwise, total, no, everywhere. Okay.
Oh, Sheila ma'am, you
So-
are our inspiration.
Thank you.
If I may be allowed to say my 2 pence.
Yes, ma'am.
Obviously, as I wrote in my comment, Dr. Sheila, talking about PPH is like doing a Sundarkand part, and your talk, this one, which which covers every aspect. So anticipation from antenatal time and everything, that is really so comprehensive and so to the point. And I agree with you that if we popularize the use of NASD garment, a lot of near miss cases would be stable when they reach the higher centers. I'll be you'll be happy to know that recently I did a workshop with our Rewari district nurses and the deputy medical officer. He told me, "Madam, हमें खरीदवा दो, बस हमें ये NASD garment का वो बता दो." And because Haryana is unfortunately over 100, so they also want to bring it down to 70 or at least 80. So I think this is something we all have to be very conscious about, and we must do it. And I would like to share that we did a very fantastic hands-on training for NASD garment and balloon therapy by doing a PPH rescue race. So what I had asked all the teams, the medical colleges, children, we had given them little information, not everything. And then we had 6 teams in both the sets, and then we were timing them. They were recording their own technique. And then we had very sincere judges who judged them. So everybody was astounded that at one time 48 people did hands-on for NASD garment as
Wow.
well as balloon therapy. So I thought that was a novel idea, and whenever we go somewhere, Dr. Sheila, you and me, we will hold that kind of race, and offbeat. No need to give them a thing. It's not a matter of earning marks; it's a matter of training yourself. So I think that was a wonderful idea. I wanted to share it with you people.
Thank you. Thank
So,
you.
and thank you, Monica, for giving me the opportunity to listen to Dr. Sheila again.
Madam,
Thank
we are
you.
blessed-
My
we are
pleasure.
blessed to have you,
My
ma'am.
pleasure.
Thank you so much, Sheila ma'am, for leading the show. Thank you so much.
And please stay around so that you can give your inputs. for
Yeah, I
my
will
talk.
listen to you.
You always give such good inputs.
Dr. Neetu, please start.
Yes, ma'am. Thank you so much, ma'am. We have just chosen the pearls in the string of PPH management. And now I hand over my co-coordinator, Dr. Nandini, to carry forward the next session.
Good evening to one and all. It gives me a proud pleasure to introduce our next speaker, who needs no introduction. She's so well eminent speaker in the path of PPH management, and that is surgical management. Our next speaker is Dr. Mitra Saxena Madam. Madam is chairperson of Practical Obstetrics Committee, POXI. She will be talking on rationale of stepwise devascularization. To chair the session, we have three reverend chairpersons. Dr. Uma B. Deshmukh Madam. Madam is president of Bidar Obskyny Society. And Dr. Rameshwari Malshetty Madam. Madam is secretary of Bidar Obskyny Society. And our third chairperson is Dr. Usha Dodamani Madam. Madam is secretary of Gulbarga Obskyny Society. Our first chairperson, Dr. Uma Deshmukh Madam. She is the head of department of Obsgyny department in the BRIMS, Bidar. Madam is also the nodal officer of maternal mortality in Bidar district. She has been the advisory committee member for PCPNDT. She has been a trainer of trainees for SBA, comprehensive abortion care, PPIUCD, emergency maternal and child health in collaboration with Singapore team. She has held.
Thank you, madam. You can continue the next session.
Ma'am, shall I tell the beautiful and awesome award that you have been awarded in your beautiful journey? She has been awarded the Best Doctor by Endanger NGO Bangalore in 2019, and she has been honored with the Sarvottam Seva Prashasti Award by the Government of Karnataka. She has been a recipient of Sri Shakti Prashasti Award, Aspiring Woman Award, and various multiple appreciation certificates from Rotary Club. It's an honor to have you, ma'am.
Thank you. Thank you.
Our next chairperson is Dr. Rameshwari Malshetty, madam. Madam is Assistant Professor in Bidar Institute of Medical Science, and she's the Secretary of Bidar Obskyny Society. And the next chairperson is Dr. Usha Dodamani, madam. Madam is Professor and Head of Department of Gulbarga Institute of Medical Sciences. She's the Honorary Secretary of Gulbarga Obskyny Society. She's also the South Zone Yuva Foxy Award Prize winner for Best Paper Presentation, UG and PG teacher and examiner, and she is the NMC assessor. She has been involved in the Comprehensive Abortion Care Coordinator. She is the Abortion Care Coordinator for Kalburgi and a Master Trainer for BMOS. It's an honor to have you, ma'am. Please join us as the chairperson. Now I request the chairperson to please introduce our speaker for today.
Good evening, everybody. It's my pleasure to be a part of this webinar, ma'am. Thank you, Monica Singh, ma'am, and Nandini Singh. So, and I take my pleasure to introduce our today's speaker, Dr. Mitra Saxena, madam. She is a chairperson of Practical Obstetric Committee, FOXY 2021 to 24. And she's got various publications like she's the editor, FOXY Focus, Life-Saving Obstetric Surgeries, E-Bulletin Building Bridges in Corona Times, and she's a convener FOXY GCPR on Birth After Cesarean Section 2023. Madam is a member FOXY GCPR Ectopic 2020, and she's written chapters on stepwise devascularization, internal iliac artery ligation in PPH book, and she's written chapters on vacuum, operative vaginal delivery in PG textbook of obstetrics.
Ma'am, Dr. Usha, please.
Ma'am, I would like to tell the awards, ma'am. Madam has won the FOXY Dira Award 2022 and FOXY President's Appreciation Award in the year 2023. And Madam is an IMA Achiever Award in the year 2022, ma'am. So, welcome you, ma'am, for this beautiful webinar on PPH and that to the surgical management of, that is the stepwise devascularization of management of PPH. Welcome you, ma'am.
Thank you so much, Dr. Usha. And actually, thank you to Monica and the whole team, Synergy, Neetu and Nalini, and I'm missing one name, but all eminent OB-GYN from Bhopal. And I must say that you are very fortunate, Monica, that you have such a wonderful, dedicated team of people who are willing to spend their time, invest in coordinating good scientific sessions. So, to speak after Dr. Sheila Mane is a challenge in itself, because Madam is so, comprehensive in her whole talk. And so I have actually made the whole thing simple for myself. Is my screen visible?
Yes, ma'am. Slideshow.
1 second. Yeah. So actually, I will just digress a little bit. The topic that was given to me was stepwise uterine devascularization. I added the word rationale, and I would also add the word rationale of, kind of surgical management of PPH, because Dr. Sheila has already covered all the obstetric, like all the anticipation, prevention, and management, the whole scenario. I will take you through this, and please let me know what is the time that is available to me. Somebody should give me information that my time is up. So I bring you greetings from Rewari, which is a small city. It's a district actually in Haryana, south of Haryana, and that is our little city. And we are very famous because of the steam engines, which were picturized in Bollywood movies. So we all know that patient, how quickly we can lose a patient. So if it is PPH within 2 hours, well, all others will give you some hours, 12 hours for APH, 1 day for rupture uterus, and so on and so forth. So as already Dr. Mane had mentioned, that whenever we have to deal with PPH, we go stepwise.
I mean, stepwise means that we have to know what are the options. So the prevention, anticipation here, and then preventing PPH in particular by AMTSL. And these are all the steps that we have available. Lastly, if nothing works, then obstetric hysterectomy or a ligation. And we have to, we have to think on our steps while we are at the emergency. We have to make the decisions. So that is the biggest challenge. Why it's not moving? Okay. So we all know all these facts that immediately after delivery, because the placental sinuses are open, so if the normal physiological myotamponade doesn't happen, the uterine muscles don't contract and provide the living ligature, and the process of coagulation is not appropriate, then a woman can lose as much as 700 ml per minute. So imagine that, we really have to have very good physiology of the patient and coagulation profile, that she should not actually suffer from PPH. So these are, all these things make us, really be prepared, as it's so appropriate to know that if an anemic patient is going to go for labor, if we are not prepared, we have not prepared them and ourselves, our team, with the optimization of hemoglobin, already counseling them about, the need of blood transfusions, etc., then we are faltering somewhere. Now, I'm going to, focus my talk on the atonic and the traumatic PPH, because I would like to keep it a little bit, concise about the surgical management. So, okay. So now, we are all aware that whenever we are dealing with PPH, actually, I'm not going to talk about the other things, the uterotonics and the IV fluids and the second line. All those things have been covered beautifully by Dr. Mane. I'm going to stick to managing, PPH surgically. So we all have to understand that we have to know what is the site from where the hemorrhage is happening and what is the cause the hemorrhage is happening. So the two most important, I'm not covering the tissue and the thrombin, because I want to focus on the tone and the trauma. So it is atony or it is traumatic, by which it is going to, the patient is going to lose excessive blood. Also, we have to understand the bleeding is occurring from the upper segment or the lower segment, or from the cervix and vagina. So whether it is atony or it is trauma, and it from which part of the genital tract is the bleeding coming. So if we have a good etiological diagnosis, we know the site and the cause, we'll be able to plan the management very appropriately without losing much time. I will take you through this very, very important diagram to understand. I'm sure by now every obstetrician is well versed with the segmental supply of the genital tract. The S1 segment is the supply to the upper part of the uterus, that's the upper uterine segment. And if we imagine a hypothetical line drawn from the posterior aspect of the bladder at right angles to the uterus, the part above is the upper segment, and that is the S1 segment. Ascending branches of the uterine artery, descending branches of the ovarian artery, and rarely the small branch of the round ligament. So that is going to supply the upper part. The S2 segment is the lower uterine segment, the cervix, the vault, the vagina. All these parts is the S2 segment. And actually, what is bigger in size does not mean it is, very important. This which is looking smaller, this can also cause horrifying bleeding in trauma, or even at times of atony. For example, if you are dealing with a placenta previa, so it's going to be in the lower segment. So you have to understand the difference between the blood supply of the S1 segment and S2 segment in trying to arrest hemorrhage. That is why I like to stress on this, that the S2 segment is supplied by the uterine, the descending branch, the cervical, the upper vesical, vaginal and pudendal artery. What we have to remember is all these branches. See, the uterine artery is very fixed. It is a branch of the anterior division of the internal line. But these branches, the cervical, the descending uterine, the vaginal, They are very varied. They can come from each other. They can be direct branches of the anterior division. They could be, vaginal could be a branch of the inferior gluteal or the internal pudendal. The good thing about these, blood vessels, especially the uterine and the ovarians, are that these blood vessels are located subperitoneally. So they are very easily accessible. So with this knowledge in our mind, we can apply our management. So again, I would like to draw your attention how richly the anastomosis of both these sides. You see, actually, God had already prepared for this organ to be richly supplied with blood so that all the nourishment can go to the baby and, can thrive within the uterus. But also this anastomosis kind of as if God had already prepared for us that if we like to ligate the vessel over here, the uterus will not necrose because it will get collateral. Just 1 second, I'm getting a call from Dr. Devdas. 1 second. Sir, can I call you later? I am right now in a webinar. Hello? 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 Am I audible? Hello?
Yeah, yes, ma'am.
Somebody give me a feedback. Okay. So, so we have to understand that with this rich anastomosis, it helps us, it helps the baby. And we also have to understand that this is, now we have so many more modalities to understand how the blood supply of this uterus, ovary, tube, vagina, cervix all goes about. And especially when we are going to do some interventional radiology, also this knowledge is very important. The S1, S2 segment, especially then repeated hematomas, you really have to plan what modality you will use to arrest the hemorrhage. So basically, I want all of us to be focused on understanding the cause and the site. So we know the cause, we know the site, it'll be easier for us to apply our knowledge. Now this is a beautiful diagram and I will draw your attention because this kind of summarizes the whole surgical management or interventional management for PPH. Now you see, I think this is pretty simple that whenever we are doing uterine tamponade, we are putting a bulb over here which is distended so that the endometrium, this side, the basal vessels are compressed along the wall. So there is tamponading. So there is no flow from the vessels into the cavity. So that is how the uterine tamponade works. That is the strategy 1, by distending the uterine cavity or even contracting it with the cannula. Now, the second strategy is compression, where the anterior and posterior wall or two walls are approximated. Again, when they press against each other, so there is no more bleeding. The third is uterine artery ligation and uterotubal artery ligation. Now, see, one way. If we go at this, we know this is the uterine artery, this is the ascending branch, descending branch. So we here see there are the arcuate arteries and they go inside radial arteries. And then we have the basal and the spiral vessels. So it's a very beautifully adapted blood supply of uterus. So when we use this to even arrest, our compression and tamponade, what they are doing is they're pressing the vessels against each other or against a distended balloon so that there's no further bleeding. Now, when we ligate the vessels, we are closing the blood supply coming from the ascending uterine artery or the uterotubal. Now, if this is put to use even segmentally, actually we talk about stepwise devascularization, and like a theory question, we address this vessel, that vessel, and all, we go in stepwise direct methodology. But if we apply it appropriately according to how our uterus is misbehaving, we will be better off. And then the strategy 4 is internal iliac artery ligation, which is going to be supplying all. It's going to be supplying the ascending, descending, vaginal, all the vessels. So that will be the, in stepwise devascularization, we ligate the uterine, the ovarian,
one side, both sides, and finally the internal ileac. And the last strategy for surgical management of PPH is getting the uterus out. So this actually, I really love this diagram, so I thought I would share it with everybody. So as we already know, when we manage surgically PPH, so we have the compression sutures, we have the ligations, and we have the internal ileac. I will not be speaking about hysterectomy today. I'll be restricting myself to these procedures. So we all know that the management of atony is, as already specified, AMTSL, uterotonics, and you have to wait for one uterotonic to effect. And if it is not effective, if patient is continuing to bleed, then you have to think of the next step. Repeat the other dose. You've given oxytocin, then think about giving methergin or carbaprost or whatever, and prepare for the next step. So temporizing method is just arresting for temporarily. So bimanual compression or aortic compression, which is very simple. All of us should educate our nurses, because when we are at the pelvic end, managing, at the perineal end, when we are managing, inspecting the vagina, etc. for tears, they can very well put their, fist over the aorta and compress the aorta to achieve the aortic compression. So now, coming to exactly devascularization, we all understand that shutting off the blood supply to the uterus. So non-surgical methods, when we are doing compression, this is non-surgical devascularization. We are actually compressing and not allowing blood to come into the vessels. So this can be considered as temporary or non-surgical. And the minute we take off the pressure, patient may again start bleeding. And surgical, I will come to that and show you some videos also. What we have to understand is that whenever we are ligating the vessels or we are doing temporary devascularization, what we are achieving is not zero blood supply. We can never reduce the blood supply to zero in the uterus and the organs. Only thing what we can do is decrease the pulse pressure and decrease the blood flow to the pelvis, so that the clotting factors are not washed away and the inherent mechanism of coagulation comes into play, because in a low pressure flow, they will be, forming the clot, and that is the real way for actually managing PPH. That is the real way how the uterus contracts and the clot is formed, that the hemorrhage will be actually arrested. So our aim has to be quite, global, quite complete. You can't just focus on one thing and that is going to help. Everything works or nothing works. So now I'm not going to go into the details of compression sutures. There are, over 200 methods, and everybody applies a suture and just, has a suture on their name. We are very familiar with B-Lynch, modified B-Lynch, Heyman and Cho sutures. But what I would like to impress upon is, as a person who's dealing with high-risk pregnancy, all of us must have big needles, curved or straight needles. We should have chromic catgut if it is possible. Otherwise, Vicryl can do. Those who have Chromox sutures, either they can use it or they can apply the rational, which is nothing but putting two things together: the ligation of the uterine artery along with the compression suture. That is the funda of Chromox sutures, which has been developed by Dr. Mahesh Gupta. So now I just took all the diagrams only to explain that, this is the classical B-Lynch. But suppose we are having a patient who has atony from a fundal focal accreta. Now, actually, we become very, unidirectional. Whenever we are dealing with placenta previous cesarean or placenta previa, we are very focused. She may not have accreta. But what about a history? We don't give much importance to previous DNCs or something, and we will see that a good number of time there will be a focal area of the placenta which is adherent in the fundus. Now, what to do here? You can't actually, you don't need to put a whole B-Lynch. Only suppose here is the focal adherent placenta and you've removed it from here and you're expecting that the patient is going to bleed. And it is suppose at the time of cesarean section. Of course, we have to understand that during cesarean, this is very easy, fairly easy to diagnose, detect, and manage. So here it would be sensible that you ligate the uterotubal vessel of this side so that the blood flow immediately, this is going to be supplied, of course, by, collaterals, but major supply will be coming from the vessel close. So ligate this vessel and approximate these walls, and your job is done. So basically speaking, the rest of the uterus is fine. So that is why I chose to change the name, rationale of using compression and stepwise devascularization. All these multiple, methods of bringing the both the walls of the uterus together are just to cover up different types of adherent placentas here and there. Sometimes we remove the placenta and we see while we are going to close the uterus that it is welling up. So definitely from the upper segment, even if the uterus is well contracted, maybe, the bed is not contracted. So it would be sensible to put sutures through and through, rectangular sutures, so approximating the vessel walls so that there is no bleeding from that side. And before we close the uterus, we see that the bleeding is controlled. My one big learning in surgical management has been that please do not expect things to happen and settle on their own. As much as our, anesthetists love to make fun of all of us, that we try and catch RBCs, etc. But I think that it's better to always have your eye on the pulse of the patient, the blood pressure, and the bleeding within your area. If we look at all that, we would be managing the patient much more efficiently. And the rationale of using compression sutures is you approximate the two walls, and where you find that the uterus is really, very thin, not, you expect that it's not going to contract, you put your compression, whether it's box or it's oblique, but make sure that you have a place for drainage of lochia. Don't close the whole anterior and posterior wall. So that is, you can put it any which way, whether you make it a quilt or you make a Hayman or you make a B-Lynch or Joe or whatever, or your own modification, but ensure that there is area for draining the lochia, and then it's about all. And of course, ligating the vessels. So now when we talk about stepwise devascularization, the beauty is that you can save the uterus without removing it, because it actually, when you decrease the pressure head by ligating the vessels, obviously you help the uterus into contracting and controlling the hemorrhage, because the blood supply is temporarily decreased. So now we all know that S1 segment, as I said, is supplied 90% by the uterine arteries and 10% by ovarian arteries. What is important to remember is, at term when we look, this is the bigger artery and this is smaller, but all those collaterals are lying there collapsed. The minute we ligate one vessel, all the collaterals will open up. So whatever action you do, if you take the decision of ligating vessels, please do it quickly rather than debating what to do, what not to do. And we all know when we come to doing stepwise, it could be, just ligating the vessel on that side, unilateral uterine artery, or both the uterines, or you go lower at the lower level and ligate the uterine artery at a lower level, or you ligate one side or both sides, utero-ovarian. So as I already said, that the pulse pressure is reduced, and this helps in the coagulation and the arrest of hemorrhage. So good thing about these vessel ligation is that they're all easily accessible. Once you exteriorize the uterus, you'll be able to palpate and see the uterine vessels. You'll be able to see the uterotubal anastomosis. So it's not a difficult job at all. Only thing to be taken care of is the ureter, and we all know its relationship with the uterine vessels at the level of internal os. The closer you stay to the uterus, lesser chances that you'll be injuring the ureter. Now, this is a diagram from UpToDate, and I'm sure all of us are very conversant. So when we put the uterine ligature, it's at this level, at the level of internal os, because this is somewhere where we put the incision. So whenever there is extension of incision or avulsion of a uterine artery of that side, we have to ligate the vessel of the same side. And this is ascending. You can go up, and this is the uterotubal. So the ovarian artery that is coming from the infundibulopelvic ligament and its branch, the tubal artery. This is anastomosing with the uterine. So here again, you ligate. The important thing in this ligation is that whenever you're taking the bite, you have to take a bite of the good bite from the myometrium so that the suture does not avulse. Other thing is that you have to make sure that you don't puncture the veins. So it's not like this that only the artery. You have to make sure that take your needles in and out from avascular part of the broad ligament from the thickness of the myometrium, and the job is done. So now of course, we all know that this was first time done by O'Leary in 103 patients, and he was quite confident that it's arrested postpartum hemorrhage, which was not responding to classic management. So I've already enumerated all these steps. So important thing is, again, one thing is ureter, and the other thing is whenever you're taking the bundle, it's not just the uterine artery, it will also be the veins along with. So just be careful that you do not cause a hematoma. You don't, injure the whole pedicle and take a bite from the myometrium. So I'll not be going into the details of the surgical anatomy. And the next, of course, is if all these vessel ligation has not helped, then we have to go ahead and ligate the anterior division of the internal iliac artery. I always like to say turning the tap off from the top. So because that is the main vessel of the pelvis. So obviously when everything else fails in the ligation, you may have to ligate the internal iliac artery. Now, what are the candidates whenever we are dealing with, as I said in the beginning, atonic PPH, traumatic PPH? We have to see if the trauma is to the upper segment, quite obviously, these vessels, the uterine, the ovarian, they will be ligated. If the trauma is to the lower part, obviously, ligating uterine artery will not help, but ligating anterior division of internal iliac artery will help. So in stepwise devascularization, classic cases where atonic PPH, it is not amenable to uterotonics or tamponade, and there you go in for compression sutures and ligation of the vessels. Now you can do one or the other or both together. And very importantly, when you're dealing with hemorrhage during cesarean section, whether it is atony or extensions and lacerations of uterine arteries, and of course the new, chip on the block, the placenta accreta syndrome and placenta previas. So as I said, placenta previa, it will be in the lower segment. This is a little bit tricky to manage on table, but that is much better because everything is under control. You can ligate the vessel, you can put compression sutures, you can put a balloon tamponade. When abdomen is open, everything is accessible to you in managing the PPH surgically. Now, coming to actual steps of stepwise devascularization. So we need a large curved needle with vicryl suture. I use number 1 vicryl, and I like to, this is a video which I have taken from with the permission of Dr. Sumita. And if there is time, and I think everybody is, you have to externalize the uterus and then you have to palpate. So here, this is a teaching video. So this is the incision of the cesarean section, and the vessel has been palpated on the left side. This is the left side of the patient, and that's the right. So taking the bundle through the avascular part of the broad ligament, and your other hand is behind this, and the needle is brought out from the substance of the myometrium. And the good thing is that this vessel is pulsatile, so you can actually feel the vessel, and it's not difficult at all. So the same thing will be done on the right side as well. Now coming to the right side again, you can take it from anterior posteriorly or from the thickness of the myometrium and then go posteriorly. But the idea is that you should know your other hand should be behind the vessels so that no loop of the bowel or omentum comes, and you should have palpated the vessel before you pass the needle. So this is ligating the uterine vessels. If we have to ligate it low down, we need to mobilize the bladder. And if we need to ligate little up, again, we have to make use of the fact that the vessel will be visible and palpable through the broad ligament. So basically, you can keep going up or you can come down according to the effect. Now, this is actually just a teaching video to apprise the audience about how ligation is done. So going low down means that you have to dissect the bladder. It should not come, the angle of the bladder should not get incorporated in the stitch. Same thing is being done on the right side. So that is uterine artery ligation. So now when we have to ligate the uterotubal artery, so what we have to remember is that the arcade is very visible. So it's better to go from posterior aspect, and you can actually see it so clearly, and bringing it out from the muscle so that there is the vessel is ligated and pressed against the myometrium. And if you do not include a part of the myometrium, this is surely going to tear the vessel, and we're not going to achieve the desired effect. Also, what we have to just take care is that the cornu of the tube is not damaged. So you can see it's not difficult. Take it through the myometrium, bring it out from a transparent area, and then just ligate it. That's about all in ligating the vessels. Now, so what is important is that if we do it, as I said, these decisions have to be taken earlier than late. So if we are very sure about the site and the etiology of the PPH, we'll be able to take better decisions and sooner. So if it is atonic PPH we are managing and we are taking the decision of opening the abdomen, I think, compression sutures can help you. You really don't need to ligate the vessels. And if compression sutures are not helping, then think about ligating the vessels, because that should be enough to bring the two sides together. So actually it is your decision making which makes all the difference. Sometimes you are going in circles, you know the theory, but in practical cases you actually fumble. So I would say, like Dr. Sheila has mentioned, you should have a team. Whenever you are stuck in this, please don't think that your own brain will help you, because there will be so much of adrenaline. It's better to have your most trusted colleague with you, and then you take a decision together. What is good is that the reproductive function is not jeopardized because the uterus gets blood supply immediately. But yes, it has been seen because sometimes you're doing multiple things. You're doing evacuation, you're doing suction, you're doing compression, you're doing ligation. Then you be prepared that the patient may have very bad Asherman syndrome. And, infrequently there have been patients where there has been sepsis and actually, shedding of the whole uterus. So basically, this has to be done and counseled, and patient has to be debriefed what all has been done and what all should be expected. So now coming to this topic, internal iliac artery ligation, which is the last resort. I mean, this is the last step in stepwise, because if you've ligated all the vessels prior to this, and still you find that you've even done the hysterectomy and still you find that there is oozing, there is bleeding, you have to close the abdomen, you have to do something better to shut off the internal iliac artery ligation. Of course, side by side, you would have made sure that the patient's, parameters, blood products are all, replenished. Otherwise, internal iliac artery will fail if you have not taken care of the coagulopathy. So basically, this is a skilled procedure, and I have, in my tenure as chairperson, I have made sure I have trained my own self, and then I have, received very positive response from all the teachers who know this and all the people who want to learn it. So thanks to all of you that all of us are becoming more, literate with respect to where we should do it, this as a primary procedure. So whenever you're thinking of a vault, there is Voltrexis or, broad ligament hematomas, or there is, placenta accreta syndrome, it'll be better to ligate the vessel first, decrease the pressure head, decrease the obstetric hemorrhage, and then go ahead and do whatever you want to do. Because whenever it's profuse arterial bleed in vaginal tears, you cannot ligate even if the patient is anesthetized, because the bleeding is so much. So better to ligate the vessels and then repair. And here again, what I have learned and I have adopted in my practice is that whenever I'm managing a patient of PPH surgically, we put her in Lloyd Davis position. That is, abdomen and the limbs are in the extended lithotomy, so that the person who's at the perineal end can actually keep guiding us, our team, that the bleeding has stopped or not. Don't put it off till later, that when you've closed the abdomen or you're going to close the abdomen, that's the time you assess that bleeding has stopped or not. So these are all the things that we are learning on way, and I'm sure if we look up deep enough, we'll find them in the guidelines also. But anyhow, our own practice helps us develop our own guideline at least. So the most important aspect in internal iliac is, of course, learning the procedure, knowing the anatomy, having a team, and taking the decision in the right moment according to the indication with team preparedness. And as I said, in S2 segment traumatic PPH, this may be the first step to rescue, and it is effective if done bilaterally. Now we all know bilateral ligation, it decreases the pulse pressure by 85% and blood flow by 48%. And what I've been saying, that it helps in the coagulation and arrest of hemorrhage because of its modality. And this is one procedure where you really need, of course, you need teamwork for managing massive PPH, but in internal iliac ligation, you need a couple of instruments more. You need Devers, you need a right angle mixture, you need the sutures, you need a team, you need extra anesthetists, you need anesthetists to be warned that you're going ahead and doing this, or you may need a hysterectomy. You need massive transfusion protocols. Not just you, but your assistants must know what to show and what you're going to do. So friends, this is something which you should learn in peacetime, so that when you are actually confronted with it, or you're called to rescue your colleague, you all are all, you have done this exercise mentally multiple times, and you've gone through the process of opening the retroperitoneum, identifying the vessels, passing the ligature. So basically, it's not very difficult, but definitely if you apply it at the right place, in the right patient, at the right time, time is most important in, choosing this as an option. And definitely when we are in our earlier phase, we would want a hemodynamically stable patient. However, if those who are very experienced, they can even do when the patient is in shock. Anyhow, I will not go into the details. If I have time, can I show you this video of internal iliac ligation?
Yes, ma'am. Please, ma'am.
Okay. So this is a patient who had, she was actually a primey, I guess, who had been delivered. There was a vault tear. And then at the the first center where it was sent, this laparotomy was done. The hematoma was drained. And then again, this patient decompensated and was sent. And Dr. Shashi, who's my very active member of committee, and she is very proficient in doing. So this is actually, friends, she had done the hysterectomy, and so that the patient does not decompensate in the post-op, this was done. So this is on the right side. After hysterectomy, you will have appreciated that the, so the retroperitoneum is opened from the right round ligament, and now gently, only with the fingers, the dissection is carried up cranially up to the infundibulopelvic ligament. So now you will be able to see that what we are actually trying to make out is, our clues are the ureter and the psoas muscle. So the external iliac artery lies over the psoas muscle, and there is loose areolar tissue over the vessels. Now you can see that this V is very clearly visible. That, friends, is the psoas muscle. This is the external iliac artery. This is the ureter. This is the ureter. This is the internal iliac vessel. So I hope you can see that this is the bifurcation of the common iliac. This is the external iliac artery. That is the psoas muscle. This is the internal iliac artery, and this is the ureter. So if she had put, her assistants are very proficient, so they're using their fingers, but we normally put devers over here, and the ureter acts like a guide because ureter crosses the pelvic brim at sacroiliac junction and follows the internal iliac. So here is a bifurcation, here's the internal iliac, this is the external iliac, and somewhere here, this is the place where we will make fenestrations. Now, very important thing is to identify the vessel. So you press the external iliac, you'll find that the femoral vessel has disappeared. So that is how you distinguish that you do not ligate the external iliac artery. So now in the next step, we'll demonstrate how dissection is done. Can you see? I hope you can appreciate.
Yes, ma'am. Yes, ma'am.
Around 4 centimeters after the bifurcation, because actually the posterior division of the anterior iliac would have been given somewhere here. So we're going to go beyond. We don't want to compromise the blood supply of the buttock and the lower back. So this is the adventitious tissue which is being separated from over the vascular bundle. So this can be, easily cut. There's no big vessel. And this is loose areolar tissue. Probably God knew we'll like to ligate. So these vessels should be covered with areolar tissue, which should be loose and easily, cut. So this, this is your, the dissection has to be carried along the length of the artery. You have to appreciate how this dissection is being done. That is the most important part. And once the dissection has been done, so you see, this is the artery, and posterior to the artery is the vein. We do not want to damage the vein. The external iliac artery, then the external iliac vein, then the internal iliac artery, and then the internal iliac vein. That's how the vessels go around. So this is the thread. A loop of thread has been doubled up so that when it is passed through under the artery, we'll have 2 ligatures to ligate. The fenestrations have been made on either side of the artery, and you'll see how gently the mixture forceps is placed behind the artery, staying close to the artery. If you could appreciate, the vein was peeping just from underneath. And you have to remember that the artery is difficult to puncture, but the vein you can. So you have to stay very close to the artery, and you will appreciate now that the loop has been passed around the internal iliac artery. And now we have 2, ligatures, throw of ligatures to ligate. Now, important to remember, never pull the suture towards yourself, rather put the knot towards the artery, meaning don't pull it towards yourself, but go down there and ligate the vessel. So actually speaking, this is, just identifying what vessel. And of course, here, because patient had a hysterectomy, uterus was out from the arena, so it's easier to go and access these vessels. However, when the uterus is present inside, it is a little bit tough. But I thought to show this video clip. Normally, I show a teaching video where the uterus is present. So I think that is that should be sufficient for all the attendees to appreciate that this is, in hands of experts. It doesn't take much time. But of course, to reach this level, we have to practice. We have to be very familiar with the anatomy of the side wall of the pelvis. We have to really realize that where infundibulopelvic ligament will be, how high we have to take. And actually, it's not difficult. If you are very gentle and you retract well with the devers on either side parallel to each other, I mean, you can actually see these the bifurcation, identify the fork very easily and do the job. So there are some limitations to this procedure as well. Injury to the nerve, wrong vessel being ligated, common iliac or external iliac. And of course, if done delayed, and we do not achieve the expected success because there was coagulopathy. So prolonged operative time, prolonged blood loss, we may actually, this may not serve its purpose. So I think this whole presentation is too long. I was not intending to talk about obstetric hysterectomy. So let me see. So actually, I'm so sorry that I have not concluded my talk with respect to today's session. But what I would like to say is PPH management is a classic example of efficient multitasking. Recognition by close maternal monitoring before it becomes life-threatening, bleeding, vital signs, bedside examination, lab evaluation, everything, CBC, coagulation studies, fibrinogen, potassium, ionized calcium levels. And we have to remember that in acute blood loss, hemoglobin and hematocrit are not going to show immediate changes. We have to know when to expect what. And early intervention is imperative to prevent shock and inadequate perfusion and oxygenation of tissues. What we really have to remember is that do not try to, let hypothermia, acidosis, and coagulopathy set in. We have to understand the concept of damage control resuscitation, wherein we may have to stop everything, just put pressure and close the abdomen, and then come back and do the required, whether it is ligation or hysterectomy or whatever. So we all know, or we have done the hysterectomy, because for any efficient obstetrician, hysterectomy doesn't take more than 5 to 7 minutes. And but you have to understand that sometimes your anesthetist says stop means stop. You have to save the patient first, then go ahead and do whatever is important. So thank you so much. Thank you, Monica. And it has been really always very useful to talk about all these things. It's kind of mental recall for all the difficult places that we have faced. So I hope that helps my colleagues. And
Madam, we can't even begin to express how mesmerized we are. Means it is like Neetu just commented in the comment box. And madam, you are revising anatomy with us. It is so, and I took the whole videos. I have shot them with my phone so that I can pass in multiple groups, people who want to watch and see this, this live surgery. Ma'am, it's so beautiful, and you have done full justice to your chairpersonship, and there could be no better person than you.
Exactly, ma'am. It
You're
was
very
such a
benevolent.
wonderful presentation, and I'm very privileged to chair this session, Mitra ma'am. And actually, I felt like I was going to my PG days and revising my anatomy. It was so clear and cut, and it was so expressive, ma'am. Thank you so much. It was really a wonderful presentation. And thank you for giving me the opportunity, Monica ma'am and Neetu ma'am. And looking forward for more such webinars connecting the South Zone to the North Zone henceforth. Thank you so much. Thank you, one and all.
Thank you so much. Thank you so much.
Thank you. Dr. Sheila, your comments also.
Excellent demo. I can see your dedication, Mitra. I loved it. Okay.
Thank you. Thank you
I
so
mean,
much.
the way you explained the segments, which is so important. And that classification, what you have shown, that. And if you look at the FIGO guidelines, they say that damage control surgery.
Yeah.
Okay. So there comes the internal iliac artery ligation and hysterectomy. Okay. So these compression suture, all that we will be doing when the patient, we have diagnosed PPH when the patient is stable and we don't want her to bleed more. But the real expertise is required when you have to do the damage control. Okay. And the damage control surgery, and rightly pointed out, for traumatic PPH, ligation of internal iliac artery today plays a more role.
Ma'am, actually, I really like to share this, that in 2011, I did hysterectomies for 2 patients back to back for my juniors. And we were dealing in both, actually. One was Waltrexis, the other was a broad ligament hematoma. Anyhow, because when my anesthetist said, Madam, बहुत bleed कर रही है, tachycardia है, कर दो जो करना है. So all I could do was open the abdomen. It was a normal vaginal delivery, and the wall tear was missed, whatever. I don't want to mention that. And she had told me कि Madam, बहुत strong bleeder है, मैंने pack कर दिया है. So I went there and I was taking a call, क्या करें, uterus well retracted and all that. And then the minute I took out the pack and she started pouring, and immediately the anesthetist told me, इसकी pulse 140 हो गई, जो करना है करो. अब what did I know? Abdomen खोला, uterus flabby हो गया था, because obviously, what happens is when the patient loses blood,
Hypoxia.
uterus also becomes, flabby. Hysterectomy कर दी, but actually it was a Waltrexis. So what I did was total hysterectomy करके और vault पकड़ लिया. So she became immediately, stable. So we closed. It was total hysterectomy. And we could manage, actually, luckily for us, that this happened. And same night, I got a call from other doctor that there is a broad ligament hematoma. I said, oh, chalo, यहाँ तो internal ligation करते हैं. But there again, ligation could not help us, and we had to do a hysterectomy. But I had an FIR against me because I was the senior कि तुमने ligation क्यों नहीं कर रहे? मैंने कहा patient बच गई, मैं नहीं कर सकती. But when I got this opportunity to be a chairperson, honest to goodness, Dr. Sheila, I have learned it in this journey itself, and God gave me an opportunity to actually save a uterus, save a patient by doing internal iliac ligation, then repairing the wall tear very nicely, comfortably, and saving the patient only 2 units of blood. So, well, I can only say this to my friends, that it's never too late to learn and never too late to change your way of thinking. That is why I put the rationale is that हम theoretically compression नहीं सोचना है, हमें तो segmental atony भी होती है ना मैम. You will appreciate that, and that's how we will use our intelligence कि हम इसी segment में लगा दें. कोई 4 जगह चो लगा के ही थोड़ा ना किसी ने देखना है. जहां से लूज है, जहां यूट्रस नहीं कंट्रैक्ट कर रहा है, वहां को कर दो. जितनी जल्दी करोगे, you will be able to manage the PPH. That's why I took the liberty of changing
Situational awareness and decision making, two important things.
बिल्कुल बिल्कुल.
Yes, thank you. Yeah, well.
Salute to you, madam. Salute.
Thank you so much, ma'am. It was really inspiring the young generation like us to hear to Sheila Mane madam and Mitra Saxena madam, and learning a lot from you both. And we have another speaker in line from whom we can learn a lot, Dr. Nalini Mishra madam. She is Dean and Professor, LN Medical College, Bhopal, and she is also past president of Raipur OBGY Society. And she will be talking hemorrhage and coagulation. To chair this session, we have Dr. Nagaratna Gorakkal Kuntoji madam. She is president of Bagalkot OBGYN Society. Dr. Shobha V. Shavi madam, she is secretary of Bagalkot OBGY Society, and Dr. Lokeshwari K. madam, she is secretary of Chitradurga OBGY Society. Dr. Nagaratna Gorukal Kuntoji madam is professor of OBGY SNMC Bagalkot, and she is also the present president of Bagalkot OBGYN Society, and she had held many executive posts and administrative posts in Bagalkot OBGY Society. She is also the organizing secretary of Kasoga 2018, and she has area of interest in high-risk pregnancy, fetal medicine, and social obstetrics. We welcome you, ma'am, to chair this session. Our next chairperson is Dr. Shobha V. Shavi, madam. She is consultant at Sanjeevani Hospital, Ikkal, Bagalkot, and she is a great academician and many awards in her bag, with special area of interest in fetal medicine, recurrent pregnancy loss, and critical care obstetric and NDVH. We welcome you, ma'am, to chair this session. Next chairperson for this session is Dr. Lokeshwari K. madam. She is professor and unit chief at Basaveshwara Medical College and Research Center at Chitradurga, with more than 1 decade of teaching experience. She has a special area of interest in obstetric emergencies and reproductive medicine. Now I hand over the session without wasting time to our chairperson to introduce our speaker and carry forward the session.
Good evening.
Yes,
Am
madam.
I audible?
Yes, madam.
Yes.
Yes, madam.
Yeah. Yeah. First of all, I thank the organizing people to giving me an opportunity to chair this session. And it was a wonderful evening. We had excellent talks. Both the talks were excellent, and also the demonstration was also excellent. Now it's my proud privilege to introduce Dr. Nalini Mishra, Madam. Nalini Mishra, Madam, she is MD DGO. She has done DNB and MNAMS and also FICOG. She is Dean and Professor, Len Medical College, Bhopal, and she is ex-professor HOD of Government Medical College, Chhattisgarh. She is ex-president of Raipur OBG Society. Her innovations to credit are she is a done CG balloon, innovative low-cost uterine balloon tamponade, and CG drape, an innovative low-cost drape for estimating blood loss at delivery, and also innovative low-cost concept to rationalize the transfusion of blood products in PPH. She has conducted workstations, and also she is a reviewer for Jogi magazine, and she's an invited faculty in many conferences. She has done many publications, and she has more than 200 citations. And I welcome Nalini Mishra, Madam, to give her lecture.
Oh, thank you. Should I share my screen now?
Yes, ma'am. Please, ma'am.
Please, okay. So, I hope it's visible.
Ma'am, yes, ma'am. It's visible, ma'am. And it is
Okay, so
it's
first
good.
of all, Dr. Monica, thanks a lot. And thanks to Neetu and Pooja and Nandini. And after listening to wonderful talks by Dr. Sheila Mane and Mitra Madam, I'm really, I don't know what to say, but I'm standing between you and your dinner. So I'll try to finish up fast. So I'll be speaking on obstetric hemorrhages and coagulation, but somehow this slide is not moving. Yeah. So the outline is that I'll be discussing the coagulation disorders caused by obstetric hemorrhage and not the pre-existing ones. Then what is the rationale for goal-directed transfusion? What is the role of point-of-care testing in the management of coagulopathy? And by innovative concept of point-of-care testing in low and middle-income countries? And what is the latest transfusion recommendation of FOGSI, ICOG, and the take-home message? So I'll not be discussing the cases where women are already having anticoagulant and antiplatelet agents, and those who are known to have congenital bleeding disorders, we shall be excluding from our discussion and shall only be discussing the coagulopathy which develops during the course of major obstetric hemorrhage. So basically two varieties. One is dilutional coagulopathy, another is consumptive coagulopathy. So dilutional coagulopathy, as the name suggests, that the coagulation factors and platelets fall progressively as the bleeding increases. And we try to arrange blood, but in the meantime, we are pumping up the fluids. So overzealous fluid administration, and there is so much dilution of the clotting factors that the patient, there is no clotting at all, and then there is dilutional coagulopathy. Another is consumptive coagulopathy. We all know that whenever there is consumption of the coagulation factors, like for example, in the case of retroplacental hematoma, abruptio placentae, amniotic fluid embolism, or other so many factors, and the clotting factors are consumed, then there is consumptive coagulopathy. And what is the rationale to differentiate the adult non-obstetric hemorrhage from the obstetric hemorrhage? This is because most of the transfusion guidelines which are there are extrapolated from the protocols which are concerning adult non-obstetric major trauma. But there is a difference. Obstetric major hemorrhage at term is different from adult non-obstetric major hemorrhages, in that the non-obstetric hemorrhage starts in the pre-hospital period and basically results from the injury. And the obstetric hemorrhage is the result of hypofibrogenemia as the main factor. The difference number 2 is that coagulopathy in an obstetric patient starts from a different hemostatic baseline. Pedestal is different. It starts from a higher pedestal, because we all know that as the physiological change of pregnancy, the fibrinogen level, which is around 2 to 400 milligram in non-pregnant state, reaches to 400 to 600 milligram at term, and it represents around 90% of the whole volume of plasma coagulation factors by weight. So fibrinogen is the most important coagulation factor. Third difference is the underlying etiology of PPH. As has been discussed before by my previous speakers, atony and trauma, they both together, they constitute about 80% of the cases. And these cases are amenable to treatment, and then the bleeding stops without further lowering of the fibrinogen, provided we take care to avoid the dilutional coagulopathy. And how do? We do all the interventions to bring about the hemostasis, but along with the permissive hypotension. So you keep the systolic blood pressure around 90 while you are taking the measures to control the bleeding and avoid overzealous fluid administration. Rather, go for blood. So blood is needed to replace the blood in cases of major obstetric hemorrhage. Consumptive coagulopathy, the main 3 factors or main 3 situations are the placental abruption, severe preeclampsia, HELLP syndrome, and intrauterine fetal death. A little rarer one are the amniotic fluid embolism, acute fatty liver of pregnancy, sepsis, and DIC in pregnancy. So DIC in pregnancy, we all know there is concomitant overactivation of the coagulation system as well as the fibrinolytic system. It's like getting angry and getting smiling at the same time. So both things are going together. In the physiology of hemostasis, the formation of a fibrin clot is the most important step. And in the initial phase, both the external and internal coagulation pathways, they start. In the next phase, called the amplification, fibrinogen plays a pivotal role. And then the platelets come and they help in propagation of the clot and strengthening. And in the end, there is fibrinolysis. So how do we diagnose the disorders of coagulation in an ongoing hemorrhage? All of us send this routine lab coagulation screen. All of us send this CBC and platelet count along with that prothrombin time, which measures the extrinsic pathway, APTT for internal pathway, and fibrinogen levels. So these lab values are used for diagnosing the DIC in pregnancy in an ongoing hemorrhage, acute obstetric coagulopathy. There is a scoring by IST. We all know that this total score in pregnancy is 52. Otherwise, non-pregnancy, the total score is 8. And in pregnancy, if it is more than 26, and in non-pregnant, it is more than 5. So we all know the utility. But how frequently do we get the changes in the lab results? There have been studies which say that fibrinogen of less than 200 mg% is reported only in 5% of the cases where the woman bled more than 1.5 liters, nearly 1.5 liters, and 17% if she has bled around 2.5 liters of blood. Then platelet count less than 75,000% in only 5%, and prolongation of APTT when she has bled more than 3 liters. So it takes a long time for these results to come. And the bigger problem is there is so much of turnaround time. Can you wait when the woman is bleeding heavily? Can you wait for 1 hour, 2 hours, 3 hours, minimum 1 hour? Can you wait? The golden hour will go by then. So what to do? What else is there? Of course, there is point of care testing. Point of care testing has proved itself to allow the real-time monitoring and tailored approach, and it has proved to have a significant reduction in the transfusion of blood products and associated transfusion morbidity. So there is thromboelastography, rotational thromboelastography. It's a viscoelastic method which provides a graphical and numerical representation of the induced hemostasis in a sample. And the best thing is the FibDem component of it is available, result is available in 10 minutes. There only, your patient is there in OT or in labor room and you get the result there and then in 10 minutes. So there is this ROTEM. What is the principle of this ROTEM? Basically, we do not have this machine, so I have learned through the internet only. And you can see this red thing. It's a cup where the blood is kept and there is an oscillating pin. So this keeps on oscillating at a fixed frequency. There is a mirror. And when the blood starts coagulating, the oscillating pin feels the resistance. And this resistance is reflected via a light source, which is reflected through it to a detector and onto a screen. And we get this resistance in a graphical manner on this screen. So whatever is the amplitude of that graph, it tells us about the amount of or level of fibrinogen in the woman's blood. There are so many output variables. We don't need to discuss all of these here. The most important thing is this is the normal graph which we get, and we have to just understand that an amplitude at 10 minutes is directly proportional to the fibrinogen level. So 6 millimeter, if the amplitude is, that is equivalent to 100 milligram of percent of fibrinogen. About 12 millimeter is 200 milligram percent of fibrinogen. Then there are various criteria of ROTEM guided analysis. There is one very interesting analogy of drinking glasses. So you can see this is the normal. The blue one is the normal graph. And this is brandy sniffer type of glass, and that is considered to be normal. And there is one wine glass graph, and there is factor deficiency, champagne glass is fibrinogen deficiency, test tube type of profile, there is platelet deficiency, inverted martini glass is the more fibrinolysis. So this is really interesting. But what I want to convey is that the transfusion should be goal directed rather than empirical. So starting with the fibrinogen, low level of fibrinogen, whenever the level of fibrinogen drops down below 200 milligram percent, it itself is an independent risk factor for the means massive amount of bleeding which is due, which can be expected or which can be predicted. So the guidelines everywhere, they say you replenish fibrinogen whenever the levels go below 200 milligram percent or 2 grams per liter. So we'll stick to milligram percent to maintain the uniformity. And there are so many protocols based on ROTEM in various centers across the world. I have taken one example that after 1 liter of blood loss, they send the blood sample to for FibDem. The result is available in 10 minutes. If the FibDem is 16 millimeter, so around 300 milligram percent, as I said, around 6 is about 100 milligram percent, 12 about 200 milligram, 16 is taken around 300 milligram percent. It is assumed, they take it for granted that all the other coagulation factors will be normal and there is no need of FFP or cryoprecipitate. So if the FibDem value is less than 12 millimeter, FFP is administered if the bleeding is ongoing. Sadly, I don't have one ROTEM, and I am sure many of us don't have a ROTEM. But we have to know the fibrinogen level for the proper implementation of the goal-directed therapy. So what do we do? At least we have one conventional point of care clotting time. We call it POCCT. That is the test of the whole blood without additive. It is suggested in the literature that if the blood in a bedside test tube or glass vial doesn't clot within 5 to 10 minutes, it may be indicative of coagulopathy. We have been taught about doing this bedside coagulation test from the time of our residency. I think 35 years back. I could get the oldest literature of 1959 advocating this test. So we thought of doing a jugaad. And what we did was we tried to correlate this bedside clotting test with the fibrinogen level of the woman to generate the evidence that how long a clotting time is equivalent to what level of fibrinogen. So that was our primary original study. And yeah, this study was published by IJGO, International Journal of Obs-Gynae, by Figo House, Oxford publication, 9-page article in 2-3 years back only. So that was an original concept. We wanted to generate the evidence. So what we did, when in a case of major primary postpartum hemorrhage, before starting anything, we generally take that sample as is the protocol, take 20 ml of blood for investigation in case of major PPH. So here we have taken 2 ml of blood in a test tube, but many a times we did not have a test tube. So we took the cleaned glass vials and we took 2 ml of blood in that. And in the same sample, from the same sample, we sent the blood for the fibrinogen assay. And the testing which we did on the bedside was that we held the tube or vial in our closed fist to keep it at a body temperature for about 4 minutes. After 4 minutes, the tube was tilted upside down every 30 seconds till the blood clotted, and the tube could be turned upside down without blood coming down. So if the clot did not, and we noted the time when the blood clotted. If the clot did not form till half an hour, then we did not pursue it further. Then once the reports from the laboratory came, then we correlated the values of the bedside coagulation test with the fibrinogen level, and we had to generate the evidence. So this was fibrinogen. We excluded those women who received blood product transfusion or colloid and ongoing anticoagulant therapy, or who were the cases of active liver disease. So our fibrinogen estimation was done primarily in these women having major PPH, but we also took few non-PPH group, normal third stage of labor women also, to know what is the common fibrinogen level in women who are not having PPH. And then we also sampled the FFP which was supplied by our blood bank. We also estimated the fibrinogen in these FFP samples also. Now, our primary outcome was the correlation of POCCT to laboratory fibrinogen value, and secondary outcome was to know the fibrinogen level in non-PPH group and FFP PEG. This is what we found. It was a very nice negative correlation. As the POCCT goes high, the fibrinogen goes low. So it was a significant Pearson coefficient. Then we divided the women in 3 groups. So that was subgroup 1, where the coagulation POCCT was less than 7 minutes. The blood clotted within 7 minutes. In these women, the mean fibrinogen level was around 450. Second subgroup, where the blood clotted between 7 to 11 minutes, the mean fibrinogen level was around 350. And where the blood did not clot till 11 minutes, it was below 200 mg%. And where it did not clot for half an hour, there it was around 100, around, to be very precise, around 122. So that was our result. We also correlated with the etiology. And as I said, in the subgroup where the blood clotted within 11 minutes, the major etiology was tone and trauma. But when it exceeded 11 minutes, the thrombus was the significant least the etiology, it increased as the etiological factor. Now, this was very interesting to know that the mean fibrinogen level in the PPH group was around 350. In non-PPH group, normal third stage of labor, it was around 600. And in the FFP, it was nearly 280, mean was 286. So you can see, if we transfuse this to these women, sometimes it may lead to a contrary result. We are liable to do more harm than good. So that is always a possibility. So we should never do that, because it will dilute, and it should be POC guided, though we should have ROTEM. And my study needs to be further validated by other studies. But if we avoid unnecessary FFP transfusions, we can prevent so many transfusion-related morbidities, hyperkalemia, acidosis, hypocalcemia, hypothermia, so on and so forth. And we have to also remember, FFP cannot be produced in factories. It is derived from the blood. So this is a very precious commodity. We should not be wasting, but at the same time, we should give it wherever it is needed. And even the IST and RCOG, they say not to transfuse FFP if laboratory test is within normal limit. But we have also developed some algorithm, though it was not our objective, but even then we developed some protocol based upon the ROTEM protocols, but it needs further research, of course. So to simplify it, we say that if the point of care coagulation test of the blood clots within 7 minutes, you are in a safe zone. You can wait, watch for further. If there is bleeding any further, you can repeat the test after some time, maybe half an hour, or earlier if they bleed. Depends upon the amount of bleeding. And if you remain in the green zone, you are safe. If you are in the yellow zone, that means CCT 7 to 11 minutes. Just be ready. Be ready. And order for FFP. If the bleeding has stopped, you can wait. If the bleeding has not stopped, you go ahead with the administration of FFP or cryofibrinogen, means anything which raises the fibrinogen. But whenever, if you are suspecting a risk factor for consumptive coagulopathy, like if she is a case of abruptio placentae or HELP syndrome or this IUFD, then go ahead with the transfusions. If it is more than 11 minutes, you are in a red zone, you are in a danger zone, go ahead with the transfusions. So same RCOG guidelines. Now, this is very interesting that very recently, just 1.5 months back, FOGSI has come up with the guidelines for blood transfusion in obstetrics and gynecology. So first of all, as Sheila Madam said, go for the build up the oxygen carrying capacity. This is the cornerstone. Then after that, there are protocols. So go for fibrinogen supplementation. If you don't have any hemostatic result and you have infused 4 units of PRBC, go for FFP at the dose of 12 to 15 ml per kg until you get the results. So you will need, for a 60 kg woman, approximately 4 packs of FFP. So I'm not going into detail for the rest of it. It's all available. And there are guidelines for the transfusion of the fibrinogen concentrate or cryoprecipitate also. If the fibrinogen level goes to a critical level below 1 gram per liter or 100 mg% or below 150 mg%, you can go for fibrinogen concentrate or cryoprecipitate. So it's fibrinogen concentrate is available by the name of Fibrogen. I think Intas people will be really happy, but I did not know that they are doing this program, but I have already incorporated it in my slides. So it is there available. dosage is 70 milligram per kg. So approximately you will need 4 grams for a 60 kg patient, and 1 gram costs around 12K. But Monica ma'am can help you to get it at a lower rates from Intas people. Then cryoprecipitate and pooling is to be done. So 5 units is one pool. Generally, we need 2 pools. And then platelet transfusion. The guideline is to transfuse whenever there is a platelet count of less than 50,000 to maintain it above that level. But if the bleeding is ongoing or you are contemplating any surgery, you just have to maintain it around 75,000 per deciliter. Single donor platelet is always better, though costlier, but it is always better. So platelet transfusion, one thing very important is that platelets are stored at 20 to 24 degree centigrade. It's not frozen or refrigerated. So what happens, this is my experience, whenever we used this platelet transfusion, there were always febrile morbidities associated with the use. Probably it has to do with the storage of this thing. Then there is recombinant factor 7A, and mode of action we all know, but the role in PPH is still under evaluation. Many countries are recommending it, but one word of caution: whenever we are going to use recombinant factor 7, you have to ensure 3 things. That is, fibrinogen level should be adequate, platelet should be adequate, and there should be no acidosis. So take care of these 3 things: correction of hypofibrinogenemia, thrombocytopenia, and acidosis. You have to correct all these, and then only you use this thing. So the approximate dose is around 2.5, means 2,400 to 4,000 for a 60 kg patient, costing around 24 to 45,000 for 1 milligram. Recombinant factor 8 and 9 is also available, and but being evaluated. Even PCC, prothrombin complex concentrate, is under evaluation. Therapeutic goals, we all know: maintain hemoglobin more than 8, platelet more than 50, PT 1.5, and fibrinogen more than 200 milligram %. Massive blood transfusion, there are definitions about that. I'll be finishing fast because we are running out of time also. One thing I want to say about the massive transfusion protocol is FIGO recommends 1:1:1 ratio. ACOG recommends 6:4:1 ratio. And utilization of this recombinant factor 7A is based upon the expert opinion. So this is the, actually it's massive transfusion protocol is when there is 1 person responsible at the obstetric end, 1 person is in the blood bank, and 1 person is the coordinator, transfusion coordinator or director. So the packs are issued in batches. So generally, as Sheila ma'am also said, in the first round, there is PRBC 6 units, FFP 6 units, platelet 6 units, or one single donor platelet, and then cryo 10 units, or 2 pooled 2 pooled units. Then second round, no platelet. Third round, recombinant factor 7, 4 and 5 again, 4, 5, 6, again the repetition of the same. But sadly, I want to say that most of the low resource setting, they do not have proper massive transfusion protocol, not even proper transfusion protocols in obstetrics. We don't use any, don't have TEG machines, but we do not even use that bedside coagulation test. And ultimately it results in poor outcome. So I'll end my talk by saying that coagulopathy associated with obstetric hemorrhage needs urgent identification and management. Fibrinogen level represents 85 to 90% of the whole amount of plasma coagulation factor by weight. Goal-directed transfusion relies on POC testing. ROTEM is not feasible for low and middle income countries, but bedside coagulation test may serve as a surrogate for fibrinogen level. We need further studies. A potential plan of pragmatic transfusion protocol based on this simple, cost-effective, readily available POC is promising. always ensure to use a glass vial. Never do it in a plastic syringe because otherwise you'll be misled. Always use a glass vial for it. And it doesn't cost anything and you don't lose anything. Only you get is information. So transfusing FFP with a fibrinogen content lower than their own to women may potentially decrease their existing fibrinogen level as well as the other clotting factors. Early fibrinogen supplementation should be considered if you think that there is a risk factor for consumptive coagulopathy. And please read the FOGSI guidelines, FOGSI ICOG guidelines, August 2024 for blood transfusion in obs and gynae. And I'm really so much thankful to you for bearing with me. Thank you so much.
Chairperson's comments, please.
Madam, that was a wonderful talk. We learned so many new things which we can use in our daily practice, because like coagulopathy is something which we are not very well versed with being obstetricians. We are very well versed with surgical management.
You're muted, Shobha.
I'm not muted, madam.
Now we can hear you.
Okay, okay. Madam, that was a very wonderful talk. We had 3 wonderful speakers, and the talk about coagulopathy is like really we learned many new things which you can really use in a day-to-day practice. Though we are well versed with surgical management, coagulopathy is something which we lag behind as obstetricians. We learned many new things today, madam. Thank you so much for this talk. And I would love to thank Dr. Monica for giving us the chance to be part of this wonderful webinar. We had 3 great speakers and all were like so extraordinary. We picked up many new things. I request you to share the recording of this webinar, madam, so that we can share in our societies also and we can revise also.
Yes, yes. So, Madam Nalini ma'am, it was a, befitting end. Like Sheila ma'am took us from the grassroots level, CHC, PHC, Tamil Nadu to Haryana. Then Mitra ma'am took us to the OT. She taught us stepwise devascularization. And you have taken us to a high-tech, futuristic vision where we have to reach. So, ma'am, our aim should be to bring that single-digit MMR to India. If that we can see in our lifetime, it will be something which we owe to our country. Like people are remembering Ratan Tata so much today. They should remember all of you. You are the masters, ma'am. You are the teachers of teachers. So, madam, ma'am, हमें आपका आशीर्वाद मिला. We are so blessed.
Thank you
Nalini,
so much.
excellent talk. Excellent talk. I have read your paper about that point of care test. You had shared it with me. And so nicely you have put how to collect the blood, because that is a big question mark in the labor room. Okay.
Yes.
And once we had a Laksha inspection and we had a hematologist from Gangaram. And she came and saw our bottle, the blood, that blue color bottle where we collect the blood for clotting, right? Coagulation profile was a pediatric one. And that means we were getting wrong reports.
Yes.
These are so small things. So I'm requesting all of you that have a look at those bottles, whether they're for adults, they're for children, how much blood to collect. And that time we realized. And that's what we discussed about Rotem and all that. It is yet to come. But point of care test today also, if my patient is bleeding, when we are drawing the blood for all the tests, I take out one syringe and put it vertically on the wall. Till your report comes, because your report is ready in 10 minutes and you know in what stage your patient is. Your coagulation profile will take 1 hour, 30 minutes, 2 hours. Okay. And a very good point, which is the new point which you have brought up, and which our evidence-based recommendation now, Sushila Rani has also mentioned about FFP. See, the FFP quantity is more. It is 200 ml.
Yes.
And you have to realize when you have to stop giving FFP because you are causing more damage.
Yes, ma'am.
One thing is you are adding volume.
Yes.
You are adding volume. That patient needs cryo. 2 pulls of cryo because the fibrinogen is very low.
Yes.
And FFP will not give you that much of fibrinogen. Yes, early phase, your patient is bleeding. The first round, you give 1:1:1. But your patient continues to bleed. you have to add that another 1 or 2 pools of cryoprecipitate.
Yes, ma'am.
Regarding fibrinogen concentrate, I would like to tell you, I am using it and I have used it. It is of so much help because by the time you arrange the cryo, it's not so easily available. You can give fibrinogen. And I have kept in my hospital, public sector hospital, I have kept 2 vials because I had a case, a primary where I had to give her 30 transfusions. I called everybody. I called the deputy director, the commissioner. I said, I don't want this patient to die. I am ordering FFP, you will get it reimbursed. And I have kept it now. We go on replacing. We gave it for ectopic pregnancy. Excellent for antepartum hemorrhage because the hypofibrinogenemia happens very soon. We gave, the hematuria got corrected. Okay. So it is available. It is 12,000. You also mentioned about prothrombin complex.
Yes.
Experience with prothrombin complex was patient was jaundiced, delivered vaginally. 80 transfusions given, anti-shock garment lagaya hai, balloon dala hai. She's still, her INR is not coming down. We can't take her for surgery. That patient, liver disorders, as such there is no role in PPH, but prothrombin complex. You get 3 and 4. You know the combination of 4 coagulant factors. It will work there. Coming to factor 7A, I must tell you, Rajasthan, all the government hospitals, it is available like anything. And we had a meeting just recently in Mumbai with this company, and all those people came. Dr. Asha from Beach Medical College, 35 cases she has used. Now, I had another case of placenta previa adherent placenta. I wanted to keep it ready, you know. Dr. Archana explained, no, posterior placenta. I had a same patient, जो लड़की मेरे हाथ में ही पैदा हुई है, अभी उसी की डिलीवरी करना था. I had to rule out whether it is adherent placenta. I got a MRI done because it was posterior. You cannot make out by ultrasound posterior placenta whether it is adherent. That is the indication for MRI. Okay, luckily it wasn't. But I had kept the interventional radiologist ready, oncosurgeon ready, fibrinogen ready. Factor 7 was not available that day. I could get only 1 gram. You will need at least 3 gram.
Yes.
Okay. So it will come to 1.5 lakhs. And in severe PPH, there is a role. How means intrinsic, extrinsic pathway.
Yes.
But factor 7 acts directly on 10. Directly there.
But the only thing is that we have to take care that there is sufficient fibrinogen platelet and there is no acidosis.
Very good point. Fibrinogen has to be more than 2 grams. Platelet more than 70,000. Then only it will act. So that means we have corrected all this. Because you mentioned in that, no, you have given the first pool, then you have given the second pool, still continuing, there is a role
Then
of
you give the recombinant factor. Yes,
yeah, recombinant factor.
Yes.
You can give fibrinogen also. And you know, one thing we have to realize, don't stop giving transfusions. Your patient is bleeding. You have to go on giving till you achieve hemostasis.
Yes.
Okay. You may have to give 30, 40, 50, 60 because, you know, the patient has gone in. And nicely explained about dilutional coagulopathy and consumptive.
Thank you so much.
That is a very good explanation. I mean, today, what a feast, Monica. And as you said, share the link. Okay.
Sheila ma'am, you are my inspiration. I want to tell everybody that because of Sheila madam, I made this Chhattisgarh balloon. She is the one who inspired me.
See, my first program as a Safe Motherhood Committee chairperson and as a vice president, when I started my PPH, I don't know, somehow I got her number. I was looking for somebody to come for other societies and I called Nalini. And Nalini was there for my first program as a guest from Raipur. Okay.
Now we are honored to have her in Bhopal. She is in Bhopal and she's in my college only.
So now Monica, Nalini, Madam Anjali, and all of you, so much of responsibility. Dr. Archana, no? You have Archana
Mishra, madam. She is the
joint
director. Yeah.
मध्य प्रदेश में
guidance, madam.
मध्य प्रदेश में ऐसा कुछ कीजिए कि बस you have to.
Yes, ma'am.
We need your blessings, ma'am, and your guidance.
Yes, sure. You all are stalwarts. And जैसे कि जुगाड़ करना तो नलिनी को पता ही है. Okay, fine. So one last word about emotive approach, WHO. You know, I did not talk about that because emotive trial was done by WHO because we are not diagnosing PPH early. We miss the diagnosis. So in E-motive, that is early diagnosis is by blood loss assessment, quantification. We have to learn that. We have to teach everybody because we miss the bus there. Okay. Vitals, shock index and all that. Then MO is massage. Uterus is atonic. O is your oxytocic. Okay. T, tranexamic. IV is your IV fluids. Okay. And if E-motive has not worked, then you escalate. So the last E is escalate. That means it is refractory PPH. Then comes your balloon, your blood transfusion, your NSG, then surgery. And if DIC, Nalini has taught us.
Madam, please put the E-motive in the group, in Synergy 3 group. Please put it.
I will do that. I will put
We will
E-motive.
circulate in all the groups, madam.
Yeah.
Thank you so much, ma'am. Thank you for your blessings. We are blessed.
You know, I am listening to all the talks. There is a birthday celebration of my husband is going on in
Madam, sir will kill me.
No, he's already told me. He's already said, what is this? I said, PPH, you have to excuse me.
Madam, your responsibilities as an obstetrician are more than your responsibilities as a wife, I think.
No, but
So,
nice, very nice.
Thank you so much, ma'am.
Nice time.
And madam, these are Intas Pharma. They are our, studio partners. They are responsible for all the beautiful webinars we are doing, madam.
अरे तो उनका ही तो है फिब्रिनोजेन.
उन्हीं का है,
मैंने
ma'am.
बोला मैडम आई टोल्ड इट, मैंने बोला भी कि मुझे नहीं पता था कि इंटास वाले कर रहे हैं, मैंने तो फिर भी डाला था.
So, ma'am,
Thank you.
Intas is
Thank you.
a
तो
very,
देख
very
लो,
well partner.
Nalini, all institutions fibrinogen is available.
So Intas, you have got social responsibility also now. Thank you. Good night, Nalini ma'am. Good night, Sheila ma'am.
Good night. Bye bye.
Good night,
Sheila
Dr.
ma'am, thank you
Shobha.
so much.
Good night, Dr. Lokeshwari. Good night, Dr. Vishal. Thank you so much for joining. Till we meet again, our next webinar is on 22nd of October. Thank you so much.
Good
Thank
night,
you.
Shubha. Good night, all my Karnataka friends, everybody.
Thank you so much.
Lata from Chennai. Yeah,
Thank
bye.
you, Kasoga, for
My
supporting us.
chairpersons.
Thank you. Thank you, ma'am. Thank you, ma'am.
Thank you.
Support team, please end the meeting.